2, 1. Please start, ma'am. We are live.
Yeah, good evening, everyone. On behalf of our medical team and Dr. From Tata, Dr. Kumar Prabhash, I welcome all the delegates as well as doctors joining us. I also welcome Dr. Advani. I see him here. So thank you, sir, for joining. And welcome to this GU Masterclass. So over to the doctors.
Good evening. Shall I start or?
Yes.
Hello.
Yes, sir, you can start. Abdul Khan, sir, you need to mute yourself. Yes, sir, you can begin.
Who will start? Yes, dear colleagues, I am really very happy to be here when we are going to discuss the whole area of prostate cancer. As all of us know, that the prostate cancer incidence is rapidly rising, basically because of the increasing lifespan. And therefore, it is very essential for all of us to know much more about it. We have to look up right from the early diagnosis, prevention to the treatment, and now the new era of molecular or precision oncology. That's where the world is moving. And as we understand more and more about the biology of the disease, we are having more and more various therapeutic methods. We also know that every ingredient of the prostate cancer, whether it is in terms of the treatment and the form of surgical treatment, the treatment with the chemotherapy, the treatment with the endocrine therapy, everything is changing and moving fast. And therefore, all of us are looking eagerly to hear from the expert as to what is really happening, how this appears to be the landmark changes in the management of the prostate cancer. Surgery has changed from the regular surgery to robotic surgery, from in the medical oncology, new chemotherapeutic agents, and now we also have the targeted therapy, which is coming up. And similarly, the more and more the stress is upon the selected therapy, that you select the particular patient for the selective drug. And I think that is what is going to be the thing for the future, that we will have the individualized treatment for everybody to get the optimum results. So with this few words, now I would request the organizers to carry on with the further whole symposium. First of all, I would like to request Dr. Ganesh Bakshi to talk to us about the screening for the prostate cancer. And he is a consultant uro-oncologist at PD Hinduja Hospital and Medical Research Center, Mumbai, and he will discuss with us how we can support the program of the breast cancer early diagnosis.
Thank you so much, sir. A very good evening to you, and thank you for giving me this talk. I'll have to share screen actually, so thank you. The topic screening for prostate cancer. I think the slide should be visible.
Yes, sir.
Yeah, so the topic, screening for prostate cancer, and briefly what the points were given to me about the talk. So as sir said, it is second most common cause coming in the men worldwide. And if we see Indian cancer registries also, the incidence is actually rising. And one of the reason is longevity, as rightly said by sir. So going ahead with the prostate cancer mortality rates, like from olden times, 1992 towards 2017, have been decreasing, and the incidence rate has been much common actually after it was very high after initially the PSA test was found, but then it has quite rationalized. So what is screening, or why should we screen anything? Screening is actually finding abnormal things in normal people so as to probably improve their quality of life and overall then the life. So risk of dying from prostate cancer is 3%, and actually if it is stage 4 at diagnosis, then sadly there is no cure. And prior to PSA screening, only 25% of prostate cancer confined to prostate presented. India is still battling a varied incidence in this particular stage, because at urban areas it may be better, but at rural and inaccessible areas it may be really bad. So why screen is actually to find early cancers, maybe to get a stage shift to the early cancer side. And what happens is most patients at early cancers are asymptomatic. So nobody is going to come to the hospital or the particular doctor with any symptom. The symptoms as urinary symptoms or pain in bones, back, blood in urine, hematuria and numbness and everything. And we kind of have now come to a rest with what are the risk factors. So age, familial cause, and there are some Afro-Asians with high risk, and there are some diets and lifestyles coming with prostate cancer. So when to suspect in a normal population, patients with lower urinary tract symptoms, but this can even mimic the benign prostate enlargement, which happens in almost 75 to 80% of the males. And if there is visible hematuria and other causes like erectile dysfunction, anything. So screening for prostate cancer might be the primary way to detect localized prostate cancer in asymptomatic individuals. It initially started long back with only digital rectal examination, which itself is actually a very crude test. Crude, I say not because we have to examine rectally, but it does help us palpate only a part of the prostate, and then the remaining sides of the prostate are not palpable. So positive predictive value of DRE is only 42%. And sometimes if the person is not experienced, again, benign, malignant, nodules, rough, firm, smooth is very difficult. So 1987 was the time when actually PSA was discovered and marketed, and this publication was there. And in 1991, just for the timeline, measurement of prostate specific antigen in serum as a screening test for prostate cancer. It was then adopted actually in the remaining part of the world. So defined populations are screened by different modalities, and one of the most primary is a PSA. We today do not use anything like DRE or MRI yet as such. Now the question is, in such a wide population or all over the world, should we screen? There are answers to that if we screen, we might get early cancers, we might save some people. There are some cons, I'll come to that. What age you should stop screening is another problem, because if we have anxiety in our mind, a person can continue doing a PSA for screening till the age of 90 also. Many advocate that men above 75 should not be screened. And there are guidelines, of course, which tell us whom to screen, and like with life expectancy of 10 years, family history, and maybe not to screen above 70 years of age. So overall, the debate is quite controversial. Does PSA-based screening lead to decrease in risk of death? If found early, yes. So it will, and it has proved so. It may prolong survival and save lives, save men from probably the stage 4 and it's related, long, painful, lot of treatments, costs. Disadvantage of screening, a very big disadvantage, overdiagnosis. So somebody might get screened, detected with a very early cancer, as sir was saying, get operated robotically or get the best radiation, and probably that person would not have the cancer progress in him at all. He would have probably died with that small cancer. So that is overdiagnosis with overtreatment, and potential decrease in quality of life with secondary, side effects of treatment modalities and the cost implications. So how we came to screening, very briefly, this was a PLCO trial from the US, prostate, lung, colorectal, ovarian. A very big number were randomized. After 7 years of death, it found no survival benefit for PSA-based screening. However, US is one of the countries which was advocating screening right, left, and center. So there were obviously some flaws in this. There was a 52% contamination, relatively low rate of biopsy in men who had abnormal screening results, and a shorter follow-up showed no benefit. This was the almost simultaneous European randomized screening for prostate cancer study, and double the number, almost 182,000, a very good age group, 50 to 74, and it showed at 9 years, 20% reduction in prostate cancer deaths. So it showed an absolute good advantage. It had numerous countries. It was obviously a multi-center trial. And to prevent one cancer death, this was at 9 years, over 1,400 men needed to be screened and 48 would require treatment. Now this statistics is very difficult. For one cancer death, so many have to be screened and 48 have to be treated with either surgery or radiation. So there are different recommendations which we need to know. In the US, screening from 55 to 69 and above 70, there is technically no screening. If there is family history or BRCA, you can. In the Canada and the Europe, it is 50 to 70. And again from Japan, from 50 years of age. So in the US, whatever happened in the last few years, there was a twist. So as I said, after the publication in 1991, it was straightforwardly advocated. And then 2012, the recommendations went that screening should be optional. This caused a lot of controversies and disease-related problems, which I'll show in some slides. And in 2017, they had to change the recommendations again. So this is what we already spoke about. And exactly 10 years back, the recommendations came as screening should be optional because you are pushing patients to overdiagnosis and overtreatment. This is the rate of overdiagnosis in both the trials. It's quite high that way. And then coming to the recommendations, if you see the 2012, the number 3, after that, because the screening was optional, the incidence decreased as the graph goes down. And what happened was, with the effect, there was decrease in the prostate cancer incidence, but in the lower box, there was increase in a distant stage prostate cancer in men above 75, as also twofold increase in metastatic disease, which again, this is a European trial which showed the benefit. And again, then the recommendations probably had to be changed to screening. Opportunistic or organized screening. Just to compare with breast cancer, initiation of widespread mammography and see the rate of incidence of metastatic disease. Almost similar has been seen with prostate cancer. So summary of major PSA screening trials is here. A recent consensus of meeting in European experts did recommend, this was in 2018 published, that limited prostate cancer screening should be rolled out. And most places the screening above 70 has not been recommended. Although there is always a dictum to that. If you have 10 years of life expectancy, maybe you can discuss with the patient. So there are always loose ends which are kept where people can be consulted, discussed, shared decision making can happen. This is a nice pathway. So for cancer referral pathway for prostate cancer, if the prostate feels malignant on digital rectal examination, in an asymptomatic or a symptomatic patient, it's slightly different. So basically the pathway comes to the same thing. We counsel the patient on pros and cons on the request of a PSA. If patient then consents, then you have to do a PSA. And obviously the consultation will explain that if the PSA is high, it might be cancer or it might be something different. Almost the same with the person with lower urinary tract symptoms. And this has come in the recent years, genetic screening. We see a lot of people who are aware of prostate cancer. We see younger age at prostate cancer today. And then there is a need. When we ask the people, patients coming to us in the clinics, they do say, I remember my father or uncle having prostate cancer. And there the role has come, as we were speaking earlier, that who needs screening. The ones, if we have people tested and with a strong family history or the BRCA and MMR genes mutated. So in them, after screening, as usual, the usual pathway can take over. And there are a few data sets which I would like to share with you. This was published from Tata Memorial Hospital. Gagan, my colleague, was the first author here. And we had just made a study of stage distribution of the cancers we see actually. So if you see our series, we used to see, this was slightly old. So 2013-14, we used to see 60% metastatic disease, which I guess today it has decreased to something like 30% probably. And we are seeing the middle group, the locally advanced. I might be wrong in saying that, but high risk, localized and the locally advanced, which is the 60% group today. So this is what, and probably I showed this graph about breast cancer and prostate cancer, and we are somewhere here in India today. We are not like the US here. So we might have some benefit. I wanted to show this follow-up of the ERSPC European Screening Trial Study. So in the 16 years of follow-up, if you really see, the number needed to screen to save one patient is 570 and number needed to treat is 18. So it has dropped from 48 to 18 as we see the longevity, as we see the people living and the long-term follow-up, because prostate cancer disease shows all the outcome at long time. It's showing a result. So this was another survey which we had done actually, and it got published in 2022. It had a question on screening actually, like to the participants, in your opinion, what kind of screening for prostate cancer is best recommended for India? So these were the results. 6% said no screening, 76% said opportunistic, 6% said population-based screening, and 12% said we should do prostate cancer screening as a health checkup plan. So that is how we got the results. And probably for screening, I feel these should be the 5 golden rules. Always explain, share decision making, discuss benefit harms. Do not screen men who will not benefit, such as those with short life expectancy, multiple comorbidities. Do not perform prostate biopsy without a compelling reason, as there are serious complications which can happen. Do not intend to treat very low or low risk prostate cancer always. Active surveillance after a MP MRI is a very good strategy. And if you have to treat, think about it, treat the person in the best possible. So who should be offered screening for prostate cancer? All men is probably no. Strong family history and HRR genetic mutations, yes. Life expectancy greater than 10 years, maybe yes. Patients who request screening, yes, after a good discussion and shared decision making. Patients, that is a patient who understands the risk and benefits. So in other words, it's called organized screening, but we should probably term it as a smart screening. And to summarize, these are the small points. Screening does have a small benefit in reducing prostate cancer mortality and probably improving the quality of life. Men who are being screened should at least have a life expectancy of 10 years. Age to initiate discussion about prostate cancer screening depends on the patient's risk factor. So if it is familial or there are certain problems, then we can discuss it at an early age also. Patient with an abnormal PSA value should be referred to a proper doctor, and we do not, DRE is not the way. PSA is usually done in a part of the screening. So thank you very much. Thank you. Any questions? I'm sure.
Thank you very much. Thank you so much, Doctor, for the wonderful presentation. Any questions anyone would like to ask? If no, so then we move on to further under the session, screening and pre-operative evaluation of prostate cancer. And I would like to invite today's second speaker, Dr. Vishal Rao, who is Senior Consultant Pathologist at Indo-American Cancer Hospital and Research Institute, Hyderabad, and he's going to deliver his talk on histopathological and molecular evaluation. Over to you, sir.
Thank you. I'll try to. Is my screen visible?
Yes, sir.
I'm audible?
You are audible.
Okay.
Just make it full screen.
I have made full screen.
Yes, sir.
Okay, good evening, all. So thank you, team, to invite me for this talk. And it was a good lecture by Dr. Ganesh, sir, and made my job easy. So my talk will include the evaluation on a core biopsy, and I'll give you just a molecular overview because we have limited time for that. So this will be, my talk will be on the role of biopsy, Gleason score, and molecular evaluation. So as sir told that many patients which come are in intermediate or high risk groups because maybe due to delayed diagnosis, and there is no routine screening practice is not there, as we can see from the data available, and or a more aggressive disease profile could be the possible reason for presenting in a later stages. So many classification tools are there, but as we have seen that the most commonly used is the clinical stage, the serum PSA level, and the Gleason score for evaluation of these patients. And coming to the role of biopsy, the role of biopsy is done for the evaluation of mass lesion, elevated serum PSA levels, and whenever there is an abnormal DRE. And you always or mostly done by as a truss guided biopsy, and it can also be performed perineally or transurethral. So these are the types of biopsy which we get in a lab. The Sexton biopsy, which is a 6-core biopsy, including bilateral base, mid-gland, and apex, or an extended biopsy, where initial diagnostic procedure is many a times it is preferred. And when a Sexton biopsy has failed, and it demonstrates increased cancer detection rate, and the false negative rate is also 5% as compared to 25% in the Sexton biopsy. And saturation biopsies can be done where more than 20 cores are taken, but how much studies have shown that it does not improve cancer detection. However, it is considered only when there is a persistently elevated PSA and several prior negative biopsies were there. It includes the transition zone also. So coming to the Gleason score. So after the type of biopsy, the Gleason score, this is the original schematic diagram by Dr. Ronald Gleason. So it has few problems, that there was an inter-observer variability there in Gleason scoring 3 plus 4, 4 plus 3, and there is a problem of reproducibility. Still we see these kind of problems when we receive review cases in our lab, and it has undergone many changes. And finally, it looks like that it has now simplified. I will say that if you can see the three pattern is mostly well-formed glands with which are discrete. The lumen is good, and for pattern 4 is now all the poorly formed, fused, or cribriform. Everything is in 4, and 5 includes the tumor cells in sheets, comedonecrosis, and singly line. Dr. Epstein says, in this digital world, why are you following the schematic diagram? So this is really available on the website, and he has made this directory of all the patterns, the pattern 3, pattern 4, and pattern 5. If you have any problem, you can refer to this. So we have also validated these new Gleason scores, and we have published this also in Urology Annals. So what are the components of reporting of a Gleason score in a core biopsies? Usually we give the primary as the secondary pattern or worst pattern. Like if there are pattern 3, pattern 4, or pattern 5, then we will give 3 plus 5, because 3 is the primary pattern and 5 is the worst pattern. In cases where there is a predominantly high grade pattern and a very small low grade pattern, like 4 is predominant and 3 is small, so then we will give it 4 plus 4. We will avoid the low grade pattern. And so in reporting, we will report number of pores, the percentage involved, then again, and any other cribriform pattern is there, LVI, PNI is there, and sometimes extra prostatic fat extension also we can get. So this is a pattern 3, where you can see discrete glands are there, well-formed lumen is there, straight luminal borders, and you can draw a line around it, high power, little bit high power view. So these are well-formed glands are there. In pattern 4, they are more cribriform. As you can see, some palisading there and cribriforming sieve like these glands become fused and poorly formed. This is a little high power where you cannot see, as you can compare, there is no well-formed lumen there. You cannot draw a line around a single gland. They're all fused up. Pattern 4, more easy to pick up. It is you can see that it is in sheets and high grade tumor, and it is in sheets and nests, and comedo pattern is also considered in pattern 5. This is also a pattern 5, where you can see that cells are in sheets and nests. So, this already have explained you how to report. Usually we double the grade, 3 plus 3 if only one grade is there, and if higher grade is there, we consider that grade. A little bit different in a radical prostatectomy. I have not taken up that, but in that tertiary pattern is also there. If a pattern 5 is less than 5% in a total radical prostatectomy specimen, then we say tertiary pattern 3 plus 4, 4 plus 3, whatever primary, secondary is there, and a tertiary pattern also mentioned, but it is always mentioned in the radical specimen, because we have thoroughly seen the radical specimen. In a radical specimen, we serially slice it and submit entirely. These are few examples of 3 plus 3, where you can see here perineural invasion is there, and perineural invasion in a prostate, it should be eating the nerve more 2/3 of the nerve. And here you can see that the glands are fused, cribriform. Again, this kind of thing with this kind of fused glands were earlier were in pattern 3, but now they are considered pattern 4. Again, another perineural invasion is there. LVI, as you can see. So whatever findings you get in a core biopsy, try to report. I tell my student, because it will help in the final diagnosis and prognosis, and take further treatment actions. So what about the other types of what are the subtypes of the prostate acinar carcinoma? Because the acinar is the most common one, but there may be atrophic types, pseudohypoplastic forming. So whatever be the pattern, but according to the architecture, you have to include them, like atrophic in 3 and pseudohypoplastic in 3, like that. And mucinous will be nest and fused glands, so you can keep it in 4. And depending upon the architecture, whether they are well-formed glands or they are fused glands or they are in sheets, like signet ring cells, definitely they will be in sheets. So it is. However, small cell neuroendocrine and squamous and basaloids are not great. So this is the grade grouping also, which has been coined by Dr. Epstein. Because he has made group 1 to 5, because the patient can be explained for active surveillance, because if it is 6, usually they think I am above average tumor, and they will be hesitant to go into a active surveillance. However, when you say it is a grade group 1, prognostic grade group 1, so it will explain better. So this is the final report, how it looks on a core biopsy. You have to tell the diagnosis, what is the type of it, and then what is modified, because this is a modified Gleason. So modified Gleason, the prognostic grade, what is the group is there. Then what is the percentage of the, you can measure it also. There are two methods, whether you can measure or give an approximate percentage. LVI, PNI, as I told you, and for extra prostatic fat extension, And cribriform pattern is now an independent prognostic factor. So whenever there is a pattern 4, pattern 4 are also of 4 types: fuse, poorly formed gland, cribriform glands. So in that you have to mention whether cribriform is that. So this is a complete report on a core biopsy. You have to include all these parameters. So this is the recent 5th edition blue book, and as you can see the difference, it is more blue. So I had the opportunity to edit this book as a IR editor, and I was very happy to contribute to the books with various images and all. So what are the little bit about the updates which were there? So there is a lot of the term subtypes and variants are very interchangeably used in many places. So now the subtypes has been included only where there is morphological. It's a subtype is a morphological category, and variants will be used where reserved for genomic rather than morphological. So if there is a genomic alteration, you say it is a variant. Otherwise, it will be a subtype, which is a morphological. Other changes which are there, which highlights were that pin-like carcinoma has been reclassified as a subtype. It is just a subtype. It is not a variant. And basal cell carcinoma of the prostate is to adenoid cystic carcinoma of the prostate. And all the neuroendocrine tumors have been put it in a separate chapter. But treatment-related neuroendocrine carcinoma of prostate has been kept with the prostate only, because post-treatment there may be this transition of into a treatment-related neuroendocrine carcinoma. So it has kept with the prostate chapter only. So now just an overview of the molecular evaluation of the prostatic cancer. So as sir has included many slides on this also. So molecular testing of a tumor offers a potential biological insight to the biological behavior, and several tissue-based assays are there, and they can be they have to improve. They improve decision making of active surveillance, adjuvant therapy, and treatment for recurrence. So HRR gene is commonly found in germline and somatic mutations. Somatic mutation in DNA repair pathway gene occurs in 19% of localized prostate tumors and 23% of metastatic tumors, and most commonly found are BRCA2 and ATM gene. And these tumor mutations are often associated with germline mutation. 42% of these patients with metastatic castrate-resistant prostate carcinoma and somatic mutation in BRCA2 were found, carry this mutation in the germline. The second one is germline BRCA1 and BRCA2 mutations. They have been associated with increased risk of prostate cancer. And in particular, BRCA2 has been associated with 2 to 6 fold increase in the risk of prostate cancer. Whereas BRCA1 whereas the association of BRCA1 mutation and increased risk of prostate cancer are less consistent. And furthermore, these patients with the germline BRCA mutation, the carcinoma occur early, which is aggressive type, and is associated with significantly reduced survival time than in non-carrier patient. Third one is DNA mismatch repair. As told, tumor mutation in in these 4 genes can be seen by ISC, and they are associated with germline mutation and Lynch syndrome. Patient with Lynch syndrome may have increased risk of prostate cancer, and in particular studies shown an increased risk of prostate cancer in older patient with germline mutation of MSH2 mutation. So as you can see, we can do IST markers. So in this, you can see these MSH2, the tumor cells are there, and tumor cells have retained the stain in MSH2 and MSH6. And in the lower corner, you can see that these tumor cells are negative for the, so there is loss of staining, means there is a deficiency. So according to that, treatment are there like PARP inhibitors and DNA mismatch immune checkpoint inhibitors can be used. So there are a lot of substantial expansion on the text on pathogenesis and molecular diagnostics in prostatic adenocarcinoma has been there in the 5th edition of the WHO. And coming to somatic tumor testing, it is recommended recommend a panel of these ISC, including BRCA1, 2, ATM, and CHEK2 and CDK1, 12. And this testing can be considered in men with regional prostate cancer. And if tissue is not available, then plasma circulating tumor DNA assay can be an option, in which there is increased PSA level or the radiologically the tumor is increased. So there are many test assays like Polaris, in which 46 gene RNA expression is tested, and this helps to stratify the risk of disease. When if there is a low gene expression, then there is a low risk of disease. If it's a high, then it's a high risk of disease. And also it predicts a 10-year death rates for prostate cancers. As you can see, less than 1, it is 7 to 15, 0 to 1, and more than 2, it is 59%. The other one is Decipher test, measures the expression level of 22 RNA biomarkers involved, and it is associated with aggressive tumor and probability of metastasis in 5 years following radical prostatectomy. So Oncotype DX, as in breast, it is FDA approved. In here also, there are 12 gene panel, which represent the androgen signaling, stromal response, cellular organization, proliferation, and 5 reference genes. And it gives a score on a 10-unit scale, and it is not used in radical specimen, only in the biopsy. So this is the summary of all the molecular tests, where you can see that the Oncotype DX is done on prostate biopsies, and which will likelihood, it will tell the likelihood freedom from high grade Gleason score. And Decipher and Polaris can be done on radical specimen, which will tell the risk of metastasis and 10-year death rate. So summarizing, prostate core biopsy plays an important role in diagnosis and calculating risk assessment. All the concerning reporting points as discussed should be included, and molecular testing will improve decision making in newly diagnosed candidates. Thank you.
Thank you, sir. Thank you very much for the wonderful presentation and wonderful talk. Next, I would like to invite Dr. Gopal Sharma, who is Associate Consultant Uro-Oncology and Robotic Surgery, Max Institute of Cancer Care, Max Super Specialty Hospital, Saket, New Delhi, and he's going to talk on surgical management of locally advanced prostate cancer. Over to you, sir.
Hello, good evening, everyone. I hope you are able to hear me.
Yes, sir.
I am Dr. Gopal Sharma. I'll be talking about the surgical management of prostate cancer. So by surgical management of prostate cancer, we basically mean radical prostatectomy. Radical prostatectomy was first described by Hugh Hampton Young in the year 1904, wherein he popularized the initial surgical approach, which was perineal approach. One of the limitation of perineal approach was that there were doing lymph node dissection, a separate abdominal incision had to be given. But however, despite its limitations, it remained a popular surgical approach till 1980s, until Walsh and Donker described the initial neurovascular anatomy of the prostate and popularized the retropubic approach. Subsequently, in the 90s and early 2000s, the laparoscopic radical prostatectomy and the initial case series of robotic radical prostatectomy by Abu et al. Were described. So there are basically 3 goals of radical prostatectomy. First and foremost is cancer control. The others are preservation of continence and preservation of sexual function. So before we subject a patient to radical prostatectomy, there are some basic evaluation which needs to be done. The first one is longevity assessment and competitive mortality risk assessment. For a patient to undergo radical prostatectomy, he should have a life expectancy of at least 10 years, which can be calculated or estimated by WHO's life table analysis according to the countries, or by MSKCC male life pool expectancy analysis. There are certain basic evaluation which needs to be done, which includes sexual function analysis, urinary symptoms evaluation, and the bowel function analysis. So finally is risk assessment, which can be done by way of clinical assessment. The popular scores used are DMECO scores, EAU risk classification, or NCCN risk classification. The others are maybe it can be artificial intelligence related or gene expression testing related, which Dr. Vishal Rao had just talked about, and it can be germline related like HRR related gene mutation testing. So some staging workup is generally recommended prior to subjecting a patient to radical prostatectomy. It depends upon the risk group, the number of investigations which are recommended. For example, for very low or low risk disease, no further investigation apart from standard MP-MRI are indicated. Whereas on the other extreme end, high and very high risk disease, both abdominal imaging, including CCT abdomen plus pelvis, and imaging to rule out bony metastasis is recommended. For further in between, like intermediate risk, there are certain criteria depending upon the PSA levels. If it is more than 10 or the lymph node predicted risk is more than 10%, then abdominal or bony imagings may be recommended. Now, for the preoperative considerations, one of the important preoperative consideration is that the significant proportion of patients will have urinary incontinence after this surgery, and urinary continence usually takes some time. And there are certain pelvic floor muscle exercises called Kegel exercises, which are often prescribed to the patient. And it has been seen that if these patients are doing this pelvic floor muscle exercises for at least 1 month prior to the surgery, it results in better post-operative early continence rates that is up to 3 months. At 6 months, the outcomes may be similar if to the patients who are not doing it before the surgery. Second consideration is whether to give a neoadjuvant hormonal therapy to these patients or not. The patients who are given hormonal therapy, it has been seen that they have advantages in terms of decreased margin positivity rates, lower positive lymph node rates. There is downstaging of the disease. However, no survival advantage in terms of biochemical recurrence, cancer survival, or overall survival is seen. So therefore, the giving neoadjuvant hormonal therapy is somewhere in the gray zone, and it may or may not be preferred by every surgeon. So regarding the survival benefit, there has been a phase 2 trial in which LH-RH antagonists along with abiraterone were given, and at 4 years of follow-up, it has shown a survival benefit in terms of biochemical recurrence at more than 4 years of follow-up. But it is still a phase 2 trial, and further phase 3 trials are underway. So there are three approaches. One is open radical prostatectomy, second laparoscopic radical prostatectomy, third is robotic radical prostatectomy. As of now, in US, about 2/3 of the radical prostatectomies are done robotically, and since we don't have similar data for India, and around about that same number of robotic prostatectomies are performed, radical prostatectomies are performed robotically in India. The minimal invasive approaches have been shown in various studies to have shorter hospital stay and reduced blood transfusion. However, the oncological, urinary, and sexual outcomes are similar between the three approaches, that is open versus laparoscopic versus robotic. So regarding whether lymph node dissection needs to be performed with every radical prostatectomy or not. So one thing is clear from lymph node dissection, that it has not shown survival benefit in any of the studies done till date, but it provides important staging and prognostic information. So currently guidelines recommend performing lymph node dissection in those patients who have a lymph node invasion risk of lymph node invasion greater than 5% using one of the recommended nomograms, that is Bricanti, MSKCC, Partin, or Roche formula. Now, regarding surgical innovations have been basically to improve recovery of two functions, that is urinary continence or sexual functions. So one of the commonly discussed innovation right now is Retzia sparing. In this, this is a all posterior approach which avoids disruption of the anterior support structures of the prostate, such as puboprostatic ligaments. The advantages that has been shown by this approach in early studies have been that it improves the early continence at 1 week and 3 months. However, the outcomes of Retzia sparing and non-Retzia sparing equalize by 1 year. There have been concerns regarding higher rates of positive margin rates following Retzia sparing radical prostatectomy, and Retzia sparing is difficult to perform in patients with anterior tumors, post-URP, large prostate, and bulky median lobes. Second innovation is bladder neck sparing. Here, as you can understand by the name, the bladder neck is spared. So it has been shown to have short-term and better long-term and short-term outcomes for the continence. However, there are concerns regarding the high positive margin rates, and it should be avoided when the tumor is located at the base. So challenging scenario for this type bladder neck sparing would be the patients who have previous TURP or have large median lobes. So in literature, there have been multiple procedures described which have been shown to have effect on urinary continence, which two of which commonly described we have already discussed. The others include neurovascular preservation, sparing of external sphincter, preservation of support structures, maximal preservation of urethral length, posterior reconstruction, total anatomical reconstruction, and secure vesicourethral anastomosis. All of these methods have been shown to impact positively on the urinary continence. So regarding sexual function preservation, there are basically three types of techniques which have been described. First is standard nurse sparing. In this diagram, as we can see, this is the main bundle of the neurovascular bundle, which is located posterolateral to the prostate. In standard nerve sparing, the plane of dissection is somewhere interfacial in between the denovilous fascia and the posterior prostatic fascia, and it spares this main neurovascular bundle. But at the same time, it destroys these lateral accessory neural pathways. Now, the second other pathway which has been described is the wheel of Aphrodite. The wheel of Aphrodite or super wheel, the other advanced technique, these are usually performed in early stage of prostate cancers. And in this technique, the surgeon performs, after performing interfacial dissection in this plane, the surgeon moves anteriorly from about 7 o'clock to 11 o'clock on left side, and similarly on the right side at 1 o'clock to 5 o'clock, and then separates this tissue on this side. So these lateral accessory neural pathways are also preserved in this technique, which has been shown to have positive impact on recovery of post-operative erectile function. So this is basically a slide summarizing all the complications which can be seen and with their respective rates during robotic radical prostatectomy. So less than 1% chances of rectal and bowel injury, anastomotic or urinary leakage in about 1.2%, ureteric injury less than 1%, and significant blood loss is about 0.5 to 2%. Trocar injury, compartment syndrome, obturator nerve injury, all less than 1%, and anastomotic stricture rates which are less, about 1.5%. So this is our study from our department in which we have reported our outcomes. In this study, we reported our results on 399 patients, and we noted about overall some complication rate of about 10%, and of which minor complications, that is grade 1 and grade 2, were reported in about 6% of the patient. And on contrary to what is usually seen in Western data, is that the most of the patients in our data set had T3 disease in the final radical prostatectomy analysis. This is in contrary to the European or Western data, in which usually the localized prostate is usually seen in 4/5 of the patients, and our proportion of patients with locally advanced prostate cancer was significantly high, and therefore the margin positivity rate was on a higher side. It is about 23%, and also positive lymph node rate is about 29%. The international reported data for positive lymph node rate is also 10 to 15%. So basically, from this pathological analysis, we can say that the type of patients we perform radical prostatectomy is significantly different from what the Western data is reported. They have more localized, we have more locally advanced sort of patients. So biochemical recurrence at 1 year was 45%, and zero ped continence at 1 year was 81%. We have also compared outcomes in patients who had previously undergone TURP to those who had not undergone TURP. We noted no difference between oncological and functional outcomes. Similarly, no difference between oncological and functional outcomes were reported for patients who were elder than 75 years and who were less than 75 years in our study. So there have been 3 classical studies in literature which have compared radical prostatectomy to watchful waiting. First was SPG trial, which was done before PSA testing was readily available. And this study had shown that cancer specific survival was better in the radical prostatectomy group, that is performing radical prostatectomy, had survival advantage, but this was before the PSA era. After this, 2 surgeries had been done, which first of which is pivot trial and second is protect study. Both of these studies failed to show survival advantage, and these 2 studies had been done in the PSA era. They failed to show cancer specific survival or overall survival advantage of radical prostatectomy for watchful waiting. However, these studies had shown that with surgery, there is reduced chances of disease progression and chances of metastatic disease. So, for patients with localized prostate cancer with low risk, radical prostatectomy can be considered as one of the treatment options if the patient is seeking active treatment and he understands the trade-off between potential toxicity versus prevention of disease progression. Routine lymph node dissection is not recommended for this group of patients. However, we had a similar study. We had performed a study in which we identified patients who had low risk of prostate cancer and then underwent radical prostatectomy at our center. We noted that in our dataset, about 50% of the patients had upgrading or upstaging in the final histopathology. So, whether to offer active surveillance to patients in our routine clinical practice is a bit doubtful. It may be possible. It may be feasible for patients in the Western countries who are usually diagnosed with raised PSA on routine evaluation. However, same may not be said about our country. The second part is localized prostate cancer with intermediate risk. In both SPCG and SPCG4 and pivot trial, there was benefit in overall survival. In this group of patients, the risk of having positive lymph nodes in the intermediate group is between 3 to 20%. Therefore, for lymph node dissection in this group, patients who have a lymph node invasion risk of more than 5% using any of the nomograms, lymph node dissection is recommended in this group of patients. For high risk localized prostate cancer or locally advanced prostate cancer, radical prostatectomy can be offered as a part of multimodality treatment, and these patients should be adequately counseled that there are chances of need for additional therapy after this surgery, and routine EPLND is indicated for these patients. There is no level 1 study that has ever compared these radical treatment, that is radiotherapy and radical prostatectomy for locally advanced prostate cancer. Currently, there is one trial known as SPCG15, which is currently recruiting patients with PT3 and PT4 tumors for comparing radical prostatectomy and EBRT. So this is a table showing results of various studies which were conducted in patients who had clinically node positive prostate cancer, and summary of these studies is that the performing radical prostatectomy had survival advantage on for these patients. Therefore, long-term ADT with local control in the form of radical prostatectomy may be considered one of the treatment options in patients with clinically lymph node positive disease. So take-home message from this presentation would be that robotic radical prostatectomy has become preferred surgical approach for radical prostatectomy. Radical prostatectomy is one of the standard treatment options for management of low and intermediate risk prostate cancer. For high risk and locally advanced prostate cancer, it can be considered as part of multimodality treatment. Thank you very much.
Thank you, sir. Thank you so much for your wonderful presentation. And next, as we move on, Dr. Palak Popat has not joined us so far. So Pratik, can we move to the next speaker? Am I audible? Ayush, am I audible?
Yes, Ekta, you are clearly audible.
So I think Palak Popat ma'am has joined us or not. I don't think she has joined. So we will move to next speaker, and I would like to invite Dr. Kinjal Jani, who is Director and Head Department of Radiation Oncology at CG Cancer Center, Ahmedabad, and he's going to talk on radiotherapy in the management of locally advanced prostate cancer. Over to you, sir.
Yeah, good evening, everyone. Am I audible?
Yes, sir, very much.
So can I share my screen?
Sure, sir.
Okay, is it full screen now?
Yes, sir.
Yeah. So good evening once again. I'm going to talk about the role of radiotherapy in localized and locally advanced prostate cancers. We have heard a good talks earlier by Dr. Bakshi and Dr. Rao, and the surgical talk also has made my talk a bit clear. How to decide what treatment. So we all know the guidelines. We all know the staging. So I'll not go into the details of the staging, but this is very important as far as the radiotherapy planning is concerned. So my dose of radiotherapy for a T1 tumor might be different from a patient who has a T4 tumor, and I might add a hormonal treatment if it's a T4 tumor before I start my radiotherapy. And for any other tumors, I might start radiotherapy upfront and add the hormones concurrently. So TNM staging is very important as far as the planning of radiotherapy is concerned. And as we all know, now we are very much dependent on the grade groups, because according to the grade groups, we have the risk stratification of prostate cancers. Let me just briefly touch upon it, that a low risk group or a very low risk group, which are the groups where we are not too aggressive. If the patient's life expectancy is less, we might give them an offer of just keeping under observation, an active surveillance, or they have the option of going for a surgery or for a radical radiotherapy. The intermediate risk group, which has now changed into a favorable and unfavorable, this is an area where the radiotherapy is also different. Like for a favorable intermediate, I might not treat the nodal chain, and for an unfavorable, along with the high risk, I would treat the nodal chain along with my prostate radiotherapy. And using the hormone also changes according to the risk stratifications. So this is very important, as again told by the surgical colleague of mine also, that we consider this when we decide the treatment options for the patients. So now I'll just go through the guidelines of NCCN about all the different risk groups and just show that, my topic of discussion was the indication of radiotherapy. So I'll just briefly touch upon, where I can be of help in treating a prostate cancer patient. So when you talk about a low risk group, here I've specifically kept the 2021 guidelines, because in 2022, there is only change in the high risk group. Rest all are same. So if you're talking about the low risk group, you have the option of active surveillance, radiotherapy or a brachytherapy or surgery. And if there are adverse pictures, you can add adjuvant radiotherapy. And again, with the less life expectancy, the observation is a good choice. I'm sorry, I think something went wrong. Yeah. So for a favorable intermediate risk group, a patient has the option of either the life expectancy, patient has the option of radiotherapy or brachytherapy alone, or a surgery, and with the less life expectancy, radiotherapy or brachytherapy or observation. And for unfavorable, we add the hormones. As I was telling you during the slide about the risk stratification, you add the hormones along with radiotherapy when you are treating an unfavorable intermediate risk group, or you can have the option of adding brachytherapy also along with. So you do a partial external beam radiotherapy and partial by brachytherapy. You can do that. And again, surgery definitely is an option for this group of patients also. For high risk or a very high risk, now this in the 2022, high risk and the very high risk group has been divided into different categories. For a patient, we have the option of, again, surgery is there. For radiotherapy, the option of external beam radiotherapy with the long-term hormones plus or minus docetaxel for a very high risk was there in the 2021 guidelines. And in the 2022 guidelines, we have the option of abiraterone. So the option of hormone plus radiotherapy, hormone for 1.5 to 3 years, plus or minus abiraterone is there in the 2022 guidelines, which was not there in the 21. So a lot of changes are happening into the guidelines because of the newer molecules coming up. Again, for a high risk, we have the option of adding brachytherapy after a partial dose of radiotherapy, and hormones definitely for 1 to 3 years. And if this patient is suitable for a surgery, where you have the feeling that patient will not have a a margin positive or are not having a lymph node metastasis, and it's an easily operable case, a young patient, we might prefer going for a surgery for such patients. And for a regional group, like when there is an N1 disease, a patient who has a less than 5 years of life expectancy, you can observe or give only hope. But when the life expectancy is more than 5 years, you go for radiotherapy plus hormone, which is a preferred option. And here it is plus abiraterone. So you add abiraterone along with the radiotherapy plus hormones. So this is something which is coming up in a big way now, that you add abiraterone or docetaxel along with radiation for a high risk or for a very high risk or a nodal group patients. Now what happens? The surgeon has told exactly what I have told, and he has told that we can do surgery at all the places. And again, I'm saying that I can do radiotherapy for all such patients. So how do we decide? We used to have a lot of debates. I'm just taking you 10 years back. We used to have a lot of debates about the role of surgery versus radiotherapy for high risk patients. We all know that for a low risk, it's better to go for surgery because it's a one-day procedure and patients are discharged fast and would not require adjuvant treatment. But for a high risk where there are very high chances that the patient requires adjuvant treatment, there used to be lots of debates. So we used to discuss that surgery is done in a day, patient is discharged in a week, has bare minimum urinary incontinence because the surgical techniques have evolved. The problem with surgery was impotency, which was early onset, blood loss, stricture, infection, pulmonary embolism, which are like surgical complications. Whereas in radiotherapy, it was a long process. We used to give it almost 38 to 40 sittings earlier, and patient is to take treatment for almost 2 months. Though it was having less complications, it was well tolerated. But yeah, bowel bladder complications in a late term, the late cystitis and proctitis used to give a lot of problems. And impotency was again a part of radiotherapy treatment also, which was usually late. So we used to debate, but then the surgical field has evolved from open prostatectomy. People are now doing a lot of robotic surgeries. At my place, we only do robotic surgeries, and we do discuss all the cases before the patients are taken up for surgery also. And it has made the life of a surgeon very easy, and it's good for the patients so that we have negativity, we have less blood loss, and they discharge the patient very fast. So this has evolved in the field of surgery. Similarly, for radiotherapy, we have also had a lot of evaluation. So we were using cobalt machines, then came the linear accelerators, and we started doing the 3D conformal radiotherapies. But now we have gadgets like this. We have a Versa HD or a TrueBeam machine, which is a very high-end 6D couch image-guided radiotherapy machine. We have a tomotherapy, which is a one of its kind, which is a helical IMRT, where you can deliver radiation to different areas in a different dose, which is very precise. And again, we also have a robot in radiotherapy, which is called a cyberknife, where we can finish off the treatment for a localized prostate, a early risk prostate in 5 days only. So we also have a lot of evaluation happening in the field of radiotherapy. So we are also doing in a faster way, and we are doing less complications. So let me just brush up about the radiotherapy part. It is done by photons, or nowadays we have the option of doing a proton. So proton, we only have it in Chennai, Apollo Chennai, and in Western world, there are a lot of proton centers available. There are other ions also like carbon ion therapy. The advantage of protons or carbon ions is that it is even more conformal than the routine conformal radiotherapy machines are concerned. But again, at its cost, it's a very costly treatment. So not all patients can go for a proton, but usually we treat the patient with photons. Again, as I was saying in the guidelines, we have two options. One is an external beam radiotherapy, which we use it for majority of our patients. And second option is a brachytherapy. Brachytherapy, again, I'll show you in detail how we do a brachytherapy, which can be done 2 ways. We do a combination of external beam plus brachytherapy. Like again, these are for an unfavorable intermediate risk group or a high risk group where you want to give some dose to the nodal chain. So you use the external beam radiotherapy also, because brachytherapy cannot treat nodes. So when you want to treat nodes, you have to have external beam radiotherapy. You cannot only do brachytherapy. For in such situation, you can add brachytherapy. Usually for an unfavorable intermediate risk group, high risk or a very high risk group, we treat a prophylactic lymph node irradiation. And when there is an N1 disease, we definitely treat the nodes. We treat up to the level of common iliac nodes. Again, hormones, as I told you earlier also, we don't use it for a low or a favorable intermediate risk group. But other patients, we use hormones ranging from 4 to 6 months for an unfavorable intermediate to 2 to 3 years for a high risk group. Now, these are the pictures of our radiotherapy planning. So this is something like the first image. This is something which we used to do earlier. We just wanted to treat the nodal chain, but we were unnecessarily irradiating the bowel and bladder because we used to give one beam from anterior, one from posterior. Then we started using the bilateral beams also, but then the target was something like this. But now with IMRT or a helical IMRT or a rapid arc, we are having a conformal target like this. So you spare the bowel here, down there will be bladder which will be spared. Here you can see a prostate very well covered, sparing the rectum. You are targeting the prostate, sparing the rectum. So the life has become easier for us and for the patients. The side effects have significantly gone down with the conformal radiotherapy techniques. How do we treat patients? We treat them in a supine position with proper immobilization so that the everyday reproducibility is there. We use vacuum cushions, we use Orfit masks. Usually we treat these patients in anti-rectum position because if there is gas in rectum, it will push the prostate anteriorly. And we might, rather than treating the prostate, we might treat the part of rectum in a higher dose. So we make sure that we treat only in the empty rectum position. And when we are treating the patient on a CT, if we find out that patient's rectum is full or has gas, we tell them to pass stool or evacuate the gas and then treat them with the empty position. We treat them with a full bladder position so that bowel can be pushed upwards so that the dose to the bowel can be reduced. So this is a condition with which we treat patients for prostate. We usually do IMRT planning. We don't do a 3D planning or a conventional planning anymore. So it's a conventional IMRT or a rapid arc IMRT or a helical IMRT, which is tomotherapy. And all these IMRT treatments are delivered under image guidance. So these patients undergo daily imaging in the form of a CT scan, where we do a CT-CT matching, and then we target exactly to the prostate area and the nodal chain, sparing the normal tissues. Now we do a lot of hypofractionation. So where we do SBRT, we only give 5 fractions of radiotherapy. We can do it on a conventional linear accelerator, but for such treatments, CyberKnife is a better option. CyberKnife is a robotic radiotherapy machine where you can deliver high dose of radiation, spare the normal tissues, and finish off the treatment in 5 days. So CyberKnife is definitely a better option for a SBRT treatment. Now, the different fractionations. As you can see in the middle, the conventional fractionation was around 2 gray per day, and we were giving 37 to 40 radiations. So the dose was like 74 to 80 grays. And for a high risk, we used to go up to 81, 82 grays with a conventional radiotherapy. But now this is a preferred one. As you can see here, now moderate hypofraction is preferred option, where the CHIP protocol says, you give 20 fractions of 3 gray each, you finish off the treatment in 4 weeks. We do have the option of 25 sittings, 26 sittings, 28 sittings. So this is my favorite. I prefer doing a 2.5 gray into 28 fractions, but all 3 are equal options. So I treat for 5.5 weeks. My colleagues do treat for 4 weeks. So it's up to the clinician to decide which fractionation they want to use. And in the NCCN, for any kind of patient, any risk group, you can use this kind of fractionations, right? So people do use a short course radiotherapy and the ultra hypofractionation, where it is only giving 5 to 7 radiations, for which I said CyberKnife is better, where you give like 6 gray into 6 fractions, or you give 6.1 into 7 or 8 gray into 5 fractions. Again, it can be done for all patients, but you have to be very careful when you're irradiating patients with the ultra hypofractionation, because any change in the position of prostate, bladder, or rectum, you're going to miss the tumor and you're going to hit the normal tissue. So we have to be very careful. Now about the brachytherapy. We have the option of 2 kinds of brachytherapy. One is a permanent brachytherapy and second is a temporary brachytherapy. So temporary brachytherapy is done with two procedures. We use a iridium-192 source, and when we use a permanent brachytherapy, there are iodine, palladium, or a cesium pellets which are in the prostate, and we give a very high dose. We give like 145 to 115 gray. This is very common in the Western world, where the procedure is done by the urologist in presence of a physicist and a radiation oncologist. Now, this is the procedure of a temporary implant, where you do a perineal approach. You put these needles into the prostate area under the transrectal ultrasound. You put these needles for a couple of days. You give 3 radiations. Now, when you give 3 radiations after a week, this can be combined along with external beam radiotherapy. Only temporary brachytherapy cannot take care of for the full treatment, and you can remove it after 2nd day. So it's a 2-day patient has to keep it, which is a bit uncomfortable for the patients. But this is very easy and very comfortable for the patients, where you put this permanent pellets into the prostate. Majority of the times it is iodine-125 or palladium-103. And again, this procedure is done exactly the same way as the previous procedure. You do a transrectal sonography, you decide your plane, you ask your physicist to decide the plane, and then you put this pellets into the prostate, and which will lie there forever. It will continuously give radiotherapy to the tumor and take care of the treatment, which is a very popular treatment for a low risk group in Western world. We do have a role to play in a biochemical failure. We do have a role to play in a local recurrence along with hormones. And when there is a systemic disease, when there is a widespread metastasis, we do give radiotherapy for symptomatic bone relief. Like bone metastasis, we give palliative radiotherapy for pain relief. So we do play a role in any kind of patients. So first I discussed about the radical case. We have the role in a biochemical failure. We have a role in local recurrence, and we have a role in metastatic condition also. Post-op RT, again, this is a area where we are not very clear when to give post-operative radiotherapy. And now in the recent era, we are talking about a post-operative radiotherapy and an early salvage radiotherapy. So conventionally, post-operative radiotherapy can be delivered within first year after surgery, once the patient recovers from the operative side effects. And it's done for a T3A beyond disease, a positive margin, seminal vesicle involvement, or a node positive disease. These are the patients who would benefit after giving adjuvant radiotherapy. But now we do treat early salvage. When the patient's PSA starts increasing, we do add radiotherapy at that age. So that is up to the institute to decide what protocol they follow. And here the dose we keep is a bit lesser. We usually keep around 66 gray, but the range is from 62 to 72. If there is a gross tumor recurrence, we give up to 70 to 72 gray, but routinely we keep it around 66 gray for majority of our patients. Post-RT recurrence, we have the option of surgery, which may be feasible. For some cases, we can use hormones. We have the option of brachytherapy. And if there is a distant mets, we go for a systemic treatment. Complications. The complications of radiotherapy have reduced, but they have not completely gone. Patients do feel loose motions, abdominal discomfort, some neutropenia because of bone irradiation, burning in urine, burning in stool, while they are on radiotherapy. And the late complications, proctitis, cystitis, have significantly gone down with the newer techniques. But yeah, we do see sometimes, and it's very difficult to manage. And it's you have pity for patients when they have proctitis because of whatever the reason. If the planning is not proper, if the positioning of the treatment was not done properly, that is a horrible side effect to have. And impotency, yes, after hormone and radiotherapy, patient do develop impotency because of the neurovascular injury, but that happens usually after 1.5 years. So my take-home message after my talk is it's a team effort. You have to choose your patients. So routinely at my place, what we do is we go for a surgery for a young patient who are fit, medically fit, and they want to go for a surgery. We prefer going for a surgery for these patients unless it's a very advanced tumor where we would feel that let us give hormones and then start radiotherapy maybe after some time. Those are the patients, even in a younger age, we prefer radiotherapy. Otherwise, surgery is well preferred for younger patients. And if patient has more than one adverse features, we know that this patient has a poor prognosis. So we keep in mind that this patient would require either an adjuvant treatment or maybe a salvage treatment later on. So we keep this patient on a regular follow-up accordingly. We know that, as I discussed, modern radiotherapy has less side effects and it's well tolerated. So we are not very worried about too many side effects nowadays. And if you treat a younger patient, they recover better. Don't forget the adjuvant treatment. Again, I would like to tell the surgeons that don't forget us, even if we've operated, because if the patient has a T3B disease, please think about adjuvant or early salvage radiotherapy for a better outcome of these patients. When you do IMRT, it has to be under image guided only. So it has to be CT-based matching for all patients who are going for radiotherapy for prostate cancers. Now, again, this is something which is evolving, and I'm very much interested. I've treated a couple of patients with abiraterone along with radical radiotherapy. So this is something which is going to come up in a big way in Indian scenario also. So let us wait for that results of our country to come. But this is something which is interesting. So here I would like to end and say thank you to all. And if any questions, I'll be happy to take.
Thank you, sir. Thank you so much. Any questions? Attendees too can ask the question in the question answer section so that panelists can answer accordingly. If there are no questions, then we will move ahead. And now I would like to invite Dr. Palak Popat. Okay, doctor. She's with us, sir. So I request Dr. T.P. Sahu.
Can I do that? Because you called me, I have to be somewhere.
Okay, sir. Okay,
I'll do that and then you can take it down. Sorry.
Okay.
Sorry,
Okay.
Palak.
No issues, no issues.
So I'll just finish off.
Yeah, sure.
Kinjal, you're there?
Yes, sir. Yes, sir.
यार तेरे को लगता है सुन के लगता है हमेशा कि यार हर मर्ज की एक ही दवा है रेडियोथेरेपी.
अरे नहीं sir. We can use it. So the thing is, we have to be very.
I know, मजाक कर रहा हूँ. I'm pulling on it.
So I like this is again one of my favorite topics, oligometastatic. where
I
we
know.
have so many patients.
So just sit back and enjoy the show because it's all radiotherapy,
Sure,
right?
sure.
Once again.
Definitely, sir.
Okay, so thank you, the organizers. Sorry, Palak, I'll just be brief. My today's talk will be on oligometastatic prostate cancer. Is systemic therapy alone sufficient? And that's what I'll be talking, the systemic versus approach of some localized form, or it should be only localized disease. So I'm audible and my slides are full screen. Can someone confirm that?
Yes, sir. Very
Yeah,
good.
thank you. So a definition of oligometastatic disease in the prostate, what would you mean? By broadly, what you mean, there's no consensus as such for oligometastasis. It's a generic definition. You would find across the board people telling that less than 2, some would be telling 3, but majority do agree at this point that if something is a limited burden and probably within 5 metastasis is where the figure is hovering around. But yes, the 3 to 5 is something that could be variable as per institute. The basic thing is it should be encompassed within a radiotherapy field probably, or should be operable to a point that people could benefit on the terms of progressive survival or overall survival. And next point which I want to highlight is more of a hypothetic transitional state, which could probably is in between a localized disease and a advanced metastatic disseminated cancer. So this is something which I think best defines oligometastatic disease. And this diagram really points out from a localized disease on the left hand side, you go to oligometastatic, which is in the transition phase, to a widely metastatic castrate resistant disease if I talk of prostate cancer. And why are we talking of this oligometastatic? This slides really reflects it. And I think in India, more and more as we use the PSMA and the more modern PET scans which you use for prostate cancer, you would find and start finding this oligometastatic disease more, because you are going to pick up this asymptomatic small disease outside which are not picked up on the normal conventional scanning modalities like what we have till now, the the CT scans, the MRs, or probably the normal PET scans. And this PSMA or the choline scans or the fluorine scans is something that would pick up these things much more frequently before they are picked up on any conventional radiological features. And that is how the things evolves. Just look at, I'm not sure how many of our centers do practice this PET scans, but look at the gallium-68 PSMA or look at the fluticlovin F18 PET scans. This is again one interesting data that points out, especially for people like the surgeons, the neurosurgeons, and the radiation oncologists, that if you start doing this and there are multiple data across, that these patients, once they do the scans, even at a lower PSA, let it be less than 0.2 PSA, you would find quite a significant extra pelvic disease, which makes them patients not right for a local form of therapy. So what I mean is, this is how probably this oligometastatic disease or patients who are considered at a point curable would not be done if you start doing this sensitive scans. And that is how the world is evolving. To put this point further, this is again a study of 125 patients of prostate cancer who has relapsed with the rising PSA post a radical prostatectomy. And if you look at it, once they did a PSMA avid scans for patients who are considered to be amenable for a localized radiotherapy to the pelvic nodes, they found that 38% of these patients had a lesion outside the pelvis, and 30%, actually 1/3 of patients of those patients who had originally planned for a radiotherapy had a lesion outside the standard RT field. So considered that the chances of potentially curable does go away. There's again one more thing to it. If you look at the genomic risk modeling, and if you use the genomic risk score, it has been found not data that has to be used for the clinics as yet. But if you look at it, it is found on the high score, these patients have potentially more chances of getting a nodal disease, which makes it high risk per se, beyond the pelvic area even, and sometimes beyond the pelvis. And these patients with high risk have low chances of getting a bony metastasis. So basically, this risk score tells you of a patient, probably once it is in prime time, ready for prime time, that these patients would be there who would be eligible and would be likelihood to get more of the pelvic disease beyond the area of interest of the pelvis, but would have lesser chances of getting a bony metastasis. So the point comes is, what is the best treatment approach for oligometastatic disease? Treatment with systemic therapy alone could be one of them. Treat the prostate with systemic therapy. Along with the systemic therapy, you treat the prostate, let it be a surgery or a radiotherapy, that we will see what the data says, or we treat the metastatic sites also. The first one is a done deal. That systemic therapy is going to be there. We have to do the systemic therapy, but should we do the systemic therapy alone, or should we do something along with that to add something so that it can increase the survival, is the main thing of the question. And this again is a very interesting data, which I think very few of us have gone through. And this is a evolutionary history of the lethal metastatic prostate cancer. What they did is they actually looked at the different cell types, and they looked at the genomic studies at a particular, they ran the flow and the other genomic tests to look at the primary prostate site. And then they looked at the cells from the metastatic site, and also looked at the cells from a distant metastatic sites further. So they found that the primary and the metastasis can seed new metastasis. That's important. So necessarily it means that the metastasis need not come from the primary alone. Second, the primary mode is actually metastasis to a new site from an old metastatic site. That's what the literature tells about. Theoretically, we need to ablate both primary metastasis. So this gives a concept of irradiating both the primary and the metastatic site, because this study and this article found out, based on the test they did, that the metastasis site, which was newly developed, primarily developed from the metastatic site already that was there, rather than from the primary prostate. So with this brief, let's come to what could be the oligometastatic disease management. We know that the left blue side, which is the systemic therapy, is already a done thing. That could be a hormone therapy, like a hormone manipulation, like abiraterone, androgen deprivation therapy, or enzalutamide, or could be one of the 2 or 3 new hormone manipulations. Could be a systemic chemotherapy, what we know of the docetaxel and the cabazitaxel groups, or could be the novel agents, could be the PARP inhibitors, or also could be the immunotherapy in a select few. The question is, does the prostate directed therapy help? That could be in form of radiation and surgery in oligometastatic disease. So let's look at Stampede. That's one of the most talked about trial when you look at it. It's a trial which is well spoken in multiple meetings. Still, it is an important trial in regards to oligometastatic disease, especially radiotherapy to the primary tumor for newly diagnosed metastatic prostate cancer, a randomized phase 3 trial. What it did was it looked into and divided the patient into low risk and high risk. The low risk was around 40% of the patient. The high risk was around 60% of patients. And the evidence suggests that if you look at the patient as a whole, if you if you took the low and high risk both, it actually did not benefit to irradiate the prostate. But the good thing came that if you went ahead and looked at the patient who were of low risk, and the low risk here was defined as something which was which had a very limited disease burden and not had any disease site extra to the vertebral bodies or the pelvis or any visceral deposits. And this, when they looked at the low risk, they found, and the number was less than 4, these patients benefited from the radiation to the prostate in addition to the systemic therapy, that was androgen deprivation therapy, and in this case docetaxel. So point taken is that if you have a low risk, low disease metastatic, probably less than 4, and it is something without a visceral disease, you probably can go ahead and irradiate the prostate. That is a good data set, and a chunk of patients do benefit if you add radiotherapy to it. The second was a negative trial, the HORAD trial, but here it had a lot of criticism because it looked at only the bony deposits. It did not look into this visceral disease. So we do not know whether this patient had the visceral disease or not. That is the most important thing that went against it. It was a trial that much smaller. It had much smaller numbers compared to what we saw in the Stampede. Overall, again, this trial tells you that addition of a radiotherapy to the androgen deprivation does not help. And the most important here was the PSA had to be more than 20. And look at the patients. They had patients who had multiple disease, less than 5, more than 15 even. But look at the forest plot. Look at the top, what it looked at, less than 5. If you have a lesser load of disease, your addition radiotherapy helps. So point that is coming to is, if you have a lesser load of disease, which is metastatic, even the bony mets, your radiotherapy to the local site or the primary prostate does give a benefit in terms of survival. There are multiple trials actually testing for all this what I've spoken about. And I think gradually the world is agreeing to that point of the low risk and the radiotherapy benefit to the prostate. Can we do surgery even? Because if we look at it, traditionally it was a surgeon's area. And surgery and surgeons have been doing it for ages together, operate in oligometastatic disease, thinking that it will help the patient in terms of survival. Do we have a level 1 evidence? No, we don't have a level 1 evidence. The best we could find is a retrospective data and the small series which we've done, and we have a meta-analysis which points to one thing, that yes, with those deficiencies, it does point out that without a level 1 evidence at this point, with the data being very weak, the 10 studies which include a meta-analysis, the PFS and the OS was slightly better for the primary cytoreduction of the prostate in a patient with the oligometastatic disease. But I think the answer will be clear when the SWOG 1802 comes in. Here it is more so the systemic therapy alone versus systemic and definite radio treatment, either surgery or radiation, and then that patient goes on for a survival data. And once this data is out, I think we will be much more clearer what actually is happening. Now coming down to the last part of my talk, systemic done, prostate directed therapy done. Do we need to irradiate the metastatic deposits, and does it help? Because as I told you in the initial thing, that the most of the metastasis new sites come from the cells that are coming from the old metastatic sites. So there are two trials again, the STOMP and Oriole. If you look at it, this data comes from a data which includes multiple patients across sites, breast, colorectal, lung, prostate. This is the Saber Comet data. It's a phase 2 data. Just to make things short, this data showed that if you irradiate with the radiotherapy with the SBRT to the metastatic sites, the patients do benefit more than those patients who did not have a SBRT to the metastatic site. Now coming to the STORM trial, it's a beautiful trial. A small patient data of 62 patients. This patient had a testosterone beyond 50, and this patient were followed up for a PSA relapse. And once they had an oligometastatic disease, they were followed up on PSA. And this trial included patients who were either going to active surveillance versus you went and irradiated or operated the radiotherapy or the surgery part. And it was only localized to 1 to 3 metastatic sites. The primary endpoint was ADT-free survival. The stratification was as per PSA doubling time, that was less than 3 months or more than 3 months, and the location of meds. And the reason to start androgen deprivation therapy was either the patient gets very symptomatic or patient gets polymetastasis. So we had to give androgen deprivation, and the patients went off the trial. So basically, this is a very important small data, which is a phase 2 data. And what it tells you that if you have this patient who are having a rising PSA, who have oligometastatic, and if you irradiate the metastatic sites, as per the data, with all the criticism of a small trial of a phase 2 data, their biochemical recurrence-free survival was superior for those who actually went ahead and did the metastatic directed therapy. And this was also true for patient on the data for ADT-free survival, means the patient had longer time to receive androgen deprivation therapy if they went and irradiated the metastatic sites rather than on surveillance. It was 13 versus 21 months. Based on this, they recommended that we should be going ahead and doing phase 3 data to look at what STORM trial really told. Now coming to the last trial is the Oriole, and this is a beautiful trial. Again, one has to be careful, and just one thing we want to forget, this trial of STORM used fluorine PET scan. So this trial had patients who could be detected on high-end PET scans, very specific prostate, which normally our radiological PET scans cannot detect. So coming to the Oriole, it's again a beautiful study. It just tells you that the radiotherapy to the metastatic site does benefit than observation, but look at how it was done. You had conventional treatment imaging, and the radiation oncologist planned the radiotherapy thinking and based on the conventional imaging, and then they did a PSMA PET scan at baseline and day 180. The numbers were small again, but look at the concept. This was the radiation oncologists were blinded. They didn't know what was the data of the PSMA PET scan. So they based their planning on the conventional imaging, what normally we do today. That could be two ways of it. If your PSMA PET scan also looked at the disease load and the disease was found inside the boundaries of what the conventional radiotherapy margins would be, or it could be a subtotal consolidation, basically that you had metastatic deposit which were not picked up on conventional and was picked up on PSMA and beyond the radiation field. They looked at that if you treated all radiotherapy took care, and the radiotherapy field enclosed all the metastatic deposit, these patients did benefit in compared to those who did not and whose disease was beyond the imaging shown in the conventional. So what it points at, that if you are thinking of a systemic, of a radiation therapy or a local treatment, then you should be able to do a more sensitive PET scan, which could pick up beyond what is conventionally there today. And second, what it probably tells you that if you do it, then you should radiate it. But my take home should be, these are all early data. I do not want anyone to go home on that point that tomorrow we start doing it, but these data do point towards something that in oligometastatic disease, this is very different from resectable or borderline resectable or locally advanced. In oligometastatic is a different disease group. They should be treated differently. They should be thought about differently. But the most important, what I gather is two things. You need more sensitive PET scans. Second, you should have you should be looking at a low risk and high risk and treat this patient differently. And third thing, what I really pick up from the data that's evolving is, if you have to do something for the metastatic sites and do think of irradiating metastatic sites or metastectomy, it is not a standard, but you have to, and you should be able to irradiate the whole disease itself. But systemic therapy is the backbone on which all this treatment should go on. So oligometastatic prostate cancer is increasingly being diagnosed due to advances in molecular imaging. The treatment, systemic therapy is essential, as I told, is the backbone. RT to the primary site for the low risk only. It is not beyond the low risk. In the high risk, you don't find any advantage. The metastatic dietary therapies, the literature is only evolving. The larger phase 3 data and level 1 evidence is pending. You need better predictors to look at the lesser or more aggressive oligometastatic prostate cancer. I think that's where all the game is there, and that's where the whole things will change. So I stop here, and I could see Dr. Vineet and Dr. Kumar on the screen, and if they have something to say on this, because they work much more intensely in this field, they can really have their points.
Thank you so much, sir, for the wonderful presentation. If there are no questions, we'll move forward. And for this, I would like to invite Dr. Palak Popat, who is Associate Professor and Consultant Officer in Charge, Breast Imaging and Interventions, Department of Radiology, Tata Memorial Hospital, Mumbai. And Dr. Palak Popat is going to speak on radiological evaluation of prostate cancer. Over to you, doctor.
Thank you so much. So today's talk is directed at essentially on role of multiparametric MRI and whether it would have a role in screening or not. So talking about it, am I audible?
Yes, ma'am.
Yes, ma'am.
Yeah. All right, sure. So talking about it, well, if there is a way to avoid this, which would never be avoided, we completely respect a digital rectal examination, but yes, we see much more with an imaging. So what are the options for screening from the imaging unit that can be offered, leave alone PSA levels? So a transrectal ultrasound or an MRI or a PSMA PET CT. So this is what this is how a lesion is seen on ultrasound, and well, there's nothing really seen here except for the BPH changes. You throw in some color, and on vascularity based assessment, yes, there would be some increased vascularity here, which could be a malignancy or prostatitis. And here we have, when we do a contrast enhanced ultrasound, we further have an added value where we see an early enhancement, and okay, we are dealing with a suspicious lesion, and then a targeted biopsy from here will tell us whether it is a malignancy or not. So coming to multiparametric MRI, it is the MRI of the prostate using a specific protocol and sequences in order to aid improved detection and staging of prostate cancer. There is a paradigm shift now to detect clinically significant cancer in treatment-naive population, active surveillance when applicable, and staging in those who are already detected with significant disease. So now the next question for us is, does it have a role in screening? There are certain indications and established uses of a multiparametric MRI, which are to detect, to localize, to characterize, to stratify based as per the risk, active surveillance, Image guidance, it offers an image guidance for biopsy, for targeted biopsy, surgery, focal therapy, and radiation therapy. And now the new kid on the block is for its role on screening. So talking about a meta-analysis of 7 studies, the pooled data showed a good specificity and a sensitivity, along with a very good negative predictive value for detection of clinically significant cancer. We can do we can screen the patients on a 1.5 or a 3 Tesla. And when we say multi-parametric, it is a set of combination of a certain sequences, and that is T2, diffusion, dynamic post-contrast, spectroscopy, T1, and at least one large FOV for lymph nodes. However, multi-parametric is linked with PIRADS. So multi-parametric is a technique of acquisition where you are looking at multiple parameters, and PIRADS is a way of reporting, or it includes a lexicon, and there are a specific set of sequences which come involved in a PIRADS assessment. The major game changer here is a spectroscopy, which has not been validated as an essential reason for essential technique for a PIRADS assessment because of the inherent heterogeneity of the sequence and heterogeneous results. So when we are doing a PIRADS assessment based MP-MRI, we need a small field of view diffusion, T2, and dynamic post-contrast cases for problem solving. The anatomy is so well seen even on the MRI, and in the base, towards the base of the prostate, we have the central zone additionally, and then in the mid gland is how we have in the rest of the glands area. So we have the transition in the center, peripheral on the periphery, anterior fibromuscular stroma. Each half is divided into the left and the right, and we have an anterior and a posterior part of the transition zone, anterior for the peripheral zone, and posterolateral or posteromedial for the peripheral zone on either side. Coming down to the apex, again, apex of the prostate has a similar distribution. So what are we talking about when we talk about PIRADS? Is to detect clinically significant cancer. It is a significant move of not detecting all coming cancers, but only for the ones which are clinically significant. So we look at the ADC value in the peripheral zones, and if it falls within this range, it says that this is significant, and it would be assigned a score of 4 or 5 depending on its size or extraprostatic extension. The objective is to improve outcome for patients. The version 2 has been standardized, and it again looks at a refined version of the original PIRADS 1. PIRADS 2 is far more lucid, far more simple, and far more implementable. The aims are for, again, establishing parameters, standardized terminology, facilitate targeted biopsy, and develop a system to aid in management. It also helps to enable data collection, educate radiologists, and enhance interdisciplinary communications of what I say and what you understand from our communication is a one unified language. So we have a score of 1, 2, 3, 4, 5, where 1 is clinically significant disease. This is not about diagnosis, but this is about detecting significant cancers. So 1 is highly unlikely, 2 is unlikely, 3 is equivocal, 4 is likely to be present, and 5 is highly likely to be present. So we look at the diffusion scores in the peripheral zone for determining the PIRADS assessment. In the transition zone, we look at the T2 weighted scoring system, and we use a dynamic very, very specifically. So there is enough literature on biparametric use, eliminating the cause of a dynamic contrast enhanced MRI. But if we are giving contrast, so it is important to see the wash-in. The washout does not matter, and it does not help in the transitional zone because BPH changes often mimic malignancies in terms of contrast enhancement. So we may confine its utility more towards the peripheral zone tumors. So there needs to be a good ideal reporting checklist for having everything in place. Staging of multiparametric is important. So like over here, I have this very nice, well-confined, prostate-confined organ disease over here. Again, this is on one side involving half of the gland. Okay, there is a neurovascular bundle invasion over here for sure on the left, and here there is an obvious invasion of the seminal vesicles, clear invasion of the bladder, and clear invasion of the rectal wall posteriorly. So it has a good staging implication. Diffusion is restricted diffusion and dark on ADC. These are a paired image. So when there are too many tumors, the intercellular molecules cannot move. So that is restricted diffusion. But when I look at the ADC, so what is bright on diffusion has to be dark on ADC. If we have a coupled value of this diffusion and ADC, we go ahead with the PIRADS assessment. So what is important is if you have an imaging which is coming from outside and you do not have the ADC objective values or the subjective ADC maps, it is not reliable to assess your prostate assessment. An example of how diffusion helps. So there is this low T2 intensity lesion here, and this is bright on restricted diffusion and dark on ADC. So this is going to be a PIRAS 4 or a 5, depending on less than 1.5 or more than 1.5 centimeters. Spectroscopy helps by increase in the choline ratios, choline and the creatinine ratios, and the citrate goes down. However, it is not standardized, as I said.
Hello, ma'am. You have lost your connections. Hello. Let's wait for 2 minutes to let her rejoin. Yes, sir. I think Palak Popat ma'am has rejoined. She's having. Ma'am, are you there?
Yeah, am I audible?
Yeah, I think you lost your connection.
Network glitch.
Yeah, sure.
Yeah, so I don't know how much I could cover or when I lost my network, but could you just tell me where I was? So never mind. What I would emphasize on when we're talking about the PIRAS assessment, so that's important. We talk about lymph nodes, if it was covered or not. Lymph nodes, PSMA, PET-CT are better at detecting metastatic lymph nodes. But for us, the morphology is important, all right? But the functional aspect comes from the PSMA.
Ma'am, can you make your slide full screen?
Yeah. So spectroscopy is not yet very standardized. If it was covered, I'm not sure. Fusion biopsies are important because there are areas of negative biopsies, and especially when you're looking at an enlarged prostatic gland, that's when an MP MRI detected or guided fusion biopsy, either cognitive or using a software, is of immense value in getting a positive diagnosis. Just coming last bit to the screening aspect. So there are articles where they have researched a good meta-analysis. So PSA has its own pros and cons about high, low positive and negative predictive values and unnecessary. Yeah, it has high false and negative ranges. So looking at some role of MP-MRI of prostate in screening for prostate cancer. So next is an MRI. So it does say that MRI outperforms PSA in the identification of patients with clinically significant prostate cancer. Another study done, there's an article on multiparametric MRI for prostate cancer screening, where they have used PSA in combination with multiparametric MRI just at 1.5 Tesla, and it shows fairly accurate screening results. Using MPMRI, they say, as a follow-up test during screening would provide more accurate biopsies, prevent unnecessary prostate biopsies, and improve the characterization of prostate cancer. One of the biggest drawbacks of PSA is the increased amount of unnecessary biopsies that come along with it. A population-based prostate cancer screening was performed with MRI or ultrasound, the IP1 prostogram study. And so it had 2,034 men involved in the study, of which 408 men consented. The proportion with positive MRI results was higher than the proportion with positive PSA test. Also, a score of PIRATS 4 or 5, the proportion with positive MRI results was similar to the proportion with positive PSA test results. So it does very clearly tell us So it does summarize saying that an MRI score of 4 or 5 is associated with improved detection of clinically significant cancer without an increase in the number of men who underwent biopsy or were overdiagnosed with clinically insignificant cancer if PSA test was used alone, and ultrasound was not associated with improved screening performance. So a short non-contrast MRI may have favorable performance characteristics as a community-based screening test. And another large study published in the NEJM talking of MRI targeted or standard biopsy in prostate cancer screening. It also had 1,532 men with elevated PSA levels looking at clinically significant cancer. 21% of them had clinically significant cancer. The percentage of insignificant cancers was lower in the experimental group than the standard biopsy group, giving the conclusion that MRI with targeted and standard biopsy in men with MRI results suggestive of prostate cancer was non-inferior to standard biopsy for detecting clinically significant prostate cancer in a population-based screening by invitation, and resulted in less detection of clinically insignificant cancer. So I would like to conclude over here that it is of good prospect in future, and it may be implementable, 1, to identify high-risk patients, 2, to have a PSA screening in conjunction with an MRI, where we have the best outcome of having detecting clinically significant cancers and reducing unnecessary biopsies. Thank you so much.
Thank you, ma'am, for the wonderful speech. And any questions anyone has, we can address. Among the panelists, anyone want to ask any questions? I think there are no questions coming up. So we have with us Dr. Manish Singhal will be joining us shortly. Till then, I would like to invite Dr. Somnath Roy, who is consultant medical oncologist at Tata Medical Center, Kolkata, and he is going to talk on management of metastatic castration-resistant prostate cancer. Over to you, sir.
Good evening, everybody, my respected teachers, colleagues, and the delegates, and all the participants, and the organizer for giving me this opportunity for delivering a lecture of management of metastatic castration-resistant prostate cancer, current and future systemic therapies. So please share the slides from your end.
Okay, sure, sir. Ayush, can we do the needful?
Yeah.
Yes, ma'am. Is it visible?
Yeah, it is. Okay. So good evening, everybody. So today I'm going to talk about the current trends of systemic therapy in metastatic prostate castration prostate cancer. If we see this trend of the prostate cancer, it is definitely from non-metastatic to metastatic, the hormone sensitive, the castrate sensitive, or then goes to the, as the PSA is rising, PSA is increasing, ultimately it goes into the castration state, that is CRPC. So eventually all patient, almost all the cohort of the prostate cancer patient ultimately goes to the from hormone sensitive disease to hormone castrate resistant disease. So, but CRPC, HSPC, HRPC, these are the terms that not interchangeable, and I'm not going into the terminology. So, as we look at the clinically localized disease, when PSA is rising, the non-castrate level, again, the ultimately goes to the castrate level and rising PSA, with along with the clinical features like appearance of new metastasis, like appearance of new symptoms, and patient goes, and the testosterone level is the castrate range, and patient goes into the stage of CRPC. Sometimes there is metastasis, sometimes there is no eventual metastasis. Some occult metastasis can be there. So it can be non-metastatic CRPC or maybe metastatic CRPC. And ultimately, patient goes succumb into the terminal stage. So what is the definition of non-metastatic CRPC? Next slide, please. So patient with a rising PSA, despite ongoing androgen deprivation therapy and no detectable lesions in the CT scan or bone scan or PSMA PET, radiological evidence, no evidence of disease, but PSA rising, patient is symptomatic. Most patient with non-metastatic CRPC are presumed to have occult mets, and they're not picked up by the conventional imaging. The important, this population not included in the pivotal studies leading to the approval of variety of drugs and metastatic CRPC. I'm going into the next. If we see the another thing is PSA and what is PSA doubling time. Next slide. So as we look at these, next slide, please. If we look at the PSA level and the PSA doubling time, so it definitely inversely proportional to the proportion of patient with succumbs to the bone metastasis, appearance of new mets, or ultimately the survival is poor. Next slide, please. Yeah. So this typical plots is reveal that if PSA is if PSA and PSA doubling time, if PSA is more, the proportion of patient of bone metastasis is more. Again, the PSA doubling time, if PSA doubling time is less than 6 months, 6 to 18 months, and more than 18 months, definitely the curves gradually goes down, and the number of metastasis proportion of the patient with a metastasis is increased. A PSA doubling time is less. So in a nutshell, we can say if PSA doubling time is less, the number of rising risk of bone metastasis is more. So chances of disease progression is more. So it is inversely proportional. So PSA doubling time is also important. Less than PSA doubling time, the more chance of proportion to the spread to the disease. Next slide, please. So so it is a clear cut. This graph is shown that PSA doubling time with the relationship of the proportion of patient with bone metastasis. As it is less, the number of bone metastasis increase. So now the next generation androgen receptor inhibitor. We had abiraterone, we had enzalutamide. After that, there is several newer generation androgen receptor inhibitors was came, the apalutamide, the darolutamide, and the combinations are with ADD. The results is very encouraging. Next slide, please. So the apalutamide, enzalutamide, and darolutamide, these are the common next generation drugs that are usually tested in the clinical trials in non-metastatic prostate CRPC or non-metastatic CRPC. So recently, darolutamide is definitely structurally distinct from the apalutamide or enzalutamide, and it is characterized by low blood-brain barrier penetration. And recently, FDA has approved non-metastatic CRPC with the darolutamide in the recommendation, in the NCCN recommendation also. So what about the enzalutamide? Next slide, please. So if we look at the AFFIRM study design, is a phase 3 randomized double-blind controlled trial of enzalutamide versus placebo in metastatic CRPC post-docetaxel. So patient is randomized into enzalutamide versus placebo. The dose is standard 160 milligram once daily. The primary endpoint of this study was the overall survival. If we look at the overall survival of this AFFIRM study, next slide, median overall survival of enzalutamide arm was 18.4 months versus placebo is 13.6 months. So there is definitely with a hazard ratio of 0.63. So definitely of a gain of 4.8, near about 5 months absolute gain of the overall survival in the enzalutamide arm in this trial. So after that, this AFFIRM study, the secondary endpoints is also fulfilled with the AFFIRM and design, like proportion of patient with reduction in the PSA level by 50% or more. It is 54% versus 2%. It's a very clinical significant. Next slide. Soft tissue response, quality of life, time to PSA progression, time to first skeletal related events, SREs, and radiographic progression free survival. So all the secondary endpoints is also fulfilled with a statistically significant difference in the enzalutamide arm. So we can say in a post chemotherapy metastatic CRPC, if we offer enzalutamide, there is a around 4.8 or 5 months absolute OS benefit, and 18.4 months in the OS in these arm, and the secondary endpoints in terms of response, quality of life, time to PSA progression, time to first SREs, and radiological PFS. These are all significantly improved in the enzalutamide study. So the clinical outcome, next slide please. So clinical outcome on the overall survival, PSA progression, and I already mentioned, next slide please. So if we look at all are clinically significant in terms of OS, PSA progression, fast SREs, response, and quality of life. So the summary of AFFIRM adverse events, if we see this adverse reaction, any serious adverse event is significantly in the enzalutamide arm is 34%, like a 268 patient as giving any serious adverse effect, and the seizure is the most common adverse effect. Next slide. With five patient in this study arm was having seizure, because CNS disorder seizure is a contraindication, is a red black warning, black box warning in the enzalutamide study, enzalutamide in this category of patient. And the other symptoms like fatigue, cardiac dysfunction like myocardial dysfunctions, and deranged LFT abnormality. These are the classical side effects that is observed, but only seizure is the most common, most mentioned side effect in the enzalutamide study. It is less than 1%. This study was having this adverse effect. Discontinuation due to adverse effect is significantly very less, 8% versus 10%, and adverse effect leading to death is 3% versus 4%. So more than grade 3 and grade 4 adverse effect is quite manageable, and it is not significant. So conclusion of this AFFIRM study is enzalutamide significantly prolonged survival in patient with metastatic castrate-resistant prostate cancer post-docetaxel. Next slide. Now, the enzalutamide in docetaxel naive metastatic CRPC, if patient is not previously treated with docetaxel. Next slide. We have a previous study design. It is also a randomized phase 3 double-blind study of enzalutamide in patient with metastatic CRPC who have asymptomatic or mildly symptomatic. Next slide, please. So in these prefill design, if we look at the patient with a progressive CRPC, metastatic CRPC, chemo naive, that is docetaxel is not given in the hormone sensitive settings. The enzalutamide versus placebo, the primary endpoint of this study was radiological PFS and overall survival, and the secondary endpoints was time to initiation of chemotherapy, SREs, and response. The previous trial effect of the radiological PFS, the next slide please. The rate of radiological progression-free survival at 12 months was 65% versus 14%, and near about 80% risk reduction of radiological PFS in enzalutamide arm with a hazard ratio of 0.19, a quite significant in these hazard ratio in this population. So what is the effect on the overall survival? If we look at the overall survival, definitely median OS of 32.4 months versus 30.3 months in these arm, with a reduction of risk of death by near about 30%. So definitely there is with a hazard ratio of 0.7. So the next slide, please. Next slide. So with the hazard ratio of 0.7, reduction of death by 29% in these population in terms of overall survival. In this study, the secondary endpoints is also quietly fulfilled. All the secondary endpoints was significant statistically. Next slide, please. So median time to until initiation of cytotoxic chemotherapy, it was 28 versus 10 with a hazard ratio of 0.35. Median time to until decline in the quality of life, it is 11 versus 5.6. Median time to first SREs, 31 versus 31. And median time to until PSA progression, 11 months versus 2.8 months. So all the secondary endpoints was fulfilled in this study. So the safety profile again, next slide please. Fatigue is the most common symptoms in these populations. Other than fatigue, the back pain, constipation, arthalgia, cardiac events, hypertensions, altered ASTLD transaminitis, and seizure. These are quite negligible and manageable side effect profile in this enzalutamide pre-docetaxel arm. So we can say this pre-docetaxel in metastatic CRPC, the prefill study design enzalutamide is definitely a good options with the terms of SREs, overall survival, and radiological PFS. Next slide, please. Next, the STRIVE study for patient with progression on GnRH therapy. It is this STRIVE study is a double-blind phase 2 study with patient with a metastatic CRPC. If we look at these randomization criteria, non-metastatic or metastatic disease who are receiving GnRH therapy, no prior chemotherapy on ATD, enzalutamide versus bicalutamide. It is a bicalutamide was used 50 milligram daily plus GnRH therapy. In the study arm, enzalutamide plus GnRH therapy. The primary endpoint was progression-free survival, where the secondary endpoint was PSA response, radiological PFS, base PSA response, and time to PSA progression. If we look at the result of this study, the PSA progression-free months is median PSA progression-free survival is 8.3 months in the enzalutamide arm versus in the bicalutamide arm versus median PSA progression-free is not reached with a next slide please, with a hazard ratio of 0.19 in these population. So median PFS was 19.4 months with enzalutamide versus 5.7 months in the bicalutamide arm. And the reduced risk of progression by death near about 76% compared to the bicalutamide. And enzalutamide resulted in significant improvement in all key secondary endpoints. So conclusion of this study was enzalutamide significantly reduced the risk of prostate cancer progression or death compared to the bicalutamide in patient with non-metastatic or metastatic CRPC who is on GnRH therapy. Then again, next slide. So next slide, please. Yes, the Terrain study, for patient with on GnRH therapy who have progressed on
I
metastatic
would request you to
CRPC.
conclude your presentation in 1 minute.
Yeah. So it is also this enzalutamide versus Terrain is a multiple is a phase 3 randomized trial. Is bicalutamide plus GnRH. If we look at the endpoints of this study, definitely median time to progression and PFS is significant in the enzalutamide arm versus bicalutamide arm with a hazard ratio of 0.44. So enzalutamide significantly better PFS compared to the bicalutamide in this study. So another is COUS phase 3 pivotal study of COUS COU AA301, where the patient is abiraterone plus prednisolone randomized in the prednisolone plus placebo control study. The next slide, please. So these demographic populations of abiraterone is used in this subgroup of patient, where patient using a GnRH agonist or treated with orchidectomy and had a serum testosterone level less than 50 and treated with at least one cytotoxic chemotherapy. So if we look at the next slide, please. Next slide. Next slide. So median primary endpoints of this study was median OS. The median OS is 10. Median OS is absolute gain of median OS is 4.6 months in abiraterone plus prednisolone arm versus prednisolone plus placebo control arm. So definitely it is a very good evidence for patient with treated with abiraterone and prednisolone in cow AA301. Again, we have another trial. I'm not going into the details due to shortage of time. Next slide, please. So it is a AA302 where it's a CRPC patient with received chemo-naive patient with not received prior docetaxel used with a GnRH analog plus abiraterone, and median OS of this study is also fulfilled with a median OS of 33.4 months versus 23.4 months in this subgroup of population. So there is a consistent pattern of benefit, delays of disease progression, improved survival, overall survival, and abiraterone combination which well tolerated and maintain a safety profile. So we can say that abiraterone is also an option in pre-chemotherapy or post-chemotherapy metastatic CRPC patient. So and another some drugs is cabazitaxel and docetaxel is also there. So I think it is our next speaker will will tell into this cabazitaxel, docetaxel, as well as PARP inhibitor in the metastatic CRPC settings. So now the key conclusion of my slides is the apalutamide, darolutamide is a newer combination next generation ATD that is tested. The enzalutamide is a next generation ATD that is overall survival benefit, and abiraterone prednisolone is also tested in several randomized trials with an overall survival benefit, as well as there is benefit of radiological PFS and fast SREs, quality of life with acceptable and manageable toxicity profile. So thank you, and once in my topic of discussion.
Thank you, sir. Thank you for the wonderful presentation. And as we move ahead for the session on advanced prostate cancer, I would like to invite Dr. Manish Singhal, who is Senior Consultant Medical Oncology, Apollo Hospitals, Delhi, and he's going to talk on management of castration-sensitive prostate cancer. Over to you, sir.
Thank you very much. Can I request my slides to be shared from your end, ma'am? I've already forwarded the slides in the email.
Yeah, sure, sir. We have. Ayush, can we do the needful?
Yeah, sure, sir.
So castration-sensitive prostate cancer has really evolved, and I think all the agents which we have used, and the previous speaker has just dwelled upon, which were used in the castration-resistant phase, such as enzalutamide, abiraterone acetate, docetaxel, or for that matter, any other drug, has moved into the castration-sensitive phase. And the idea, this is not my slide set. I've forwarded a new slide set on the email which was sent to me by Mr. Agarwal. So the reason is that the longer the patient stays in a castration-sensitive phase, the quality of life is better maintained, and it is one of the endpoints to delay the castration-resistant phase to as much extent as possible, because the quality of life is better maintained in the castration-sensitive phase. But once the castration-resistant phase sets in, then the quality of life starts dipping down much rapidly. Therefore, all these agents have moved up the ladder into the castration-sensitive phase, and the first and the foremost study which happened in the castration-sensitive prostate cancer de novo, or the one which has recurred after a radical prostatectomy or a local treatment with short duration androgen deprivation. Such patients were recruited in various studies. The first and the foremost study was the chartered study, which segregated patients into high volume and low volume disease by the virtue of the number of bone metastases that they had, such as more than 4 metastases or visceral metastases. and randomize these patients to androgen deprivation therapy alone with or without docetaxel. So charter study showed that in patients who had high volume disease, there was almost an improvement of median overall survival, which was one of the primary endpoints, and showed that there was 1.5 years increase in the median overall survival, which has never been registered previously. So after the charter study, there was a parallel study, which was the study which was conducted by Stampede people, and the Stampede also showed that the addition of docetaxel with slightly different criteria. Instead of volume, they took low risk and high risk, and by the virtue of either the Gleason score, the presence of visceral metastasis, or the number of metastases in the bone being 3 or more. So that it was slightly different criteria than the chartered. And so instead of volume, they looked at risk. So any of the 2 risk factors, if they were present, the patient were either low risk or high risk. And so they also proved that, yes, the Stampede also proved that the addition of docetaxel actually leads on to improvement in survival. Thereafter, it was the abiraterone acetate which moved up the ladder, and then there were 2 major studies called as the Latitude study and another arm of the Stampede trial, which randomized patients to the addition of abiraterone acetate. The point over here, which is worthy of note, is that docetaxel was given just for 6 cycles, and then the patient was only on androgen deprivation therapy, whereas for abiraterone acetate it was up till progression. So abiraterone acetate had to be given up till progression. So so in these very studies, again, the median overall survival improved, which was the primary endpoint of most of these studies. But if you look at the hazard ratios within these studies, be it with the chartered, the Latitude, the Stampedes, the hazard ratios of overall survival was quite similar between these studies. It was around 0.72 to 0.8. So that means the quantum of improvement was quite similar with either abiraterone acetate or docetaxel. It was only the Stampede study which had a parallel randomization going on. One second. Haji.
Sorry for the interference, sir, but we didn't receive any of the slides from your end.
Gaurav Agarwal 1991@gmail.com, ma'am. This is the email which which you have sent me the.
I'll cross check, sir. I'll cross check.
Yeah. So it was the Stampede study which had a parallel randomization going on between docetaxel and a parallel randomization going on for abiraterone acetate. That was the only study which had a so-called as head-to-head comparison between docetaxel and abiraterone. In that particular, and Stampede people published that data, it was not a head-to-head comparison, but it was a parallel randomization going on in different arms. So they compared whether docetaxel is superior to abiraterone acetate in an indirect manner, and they showed that abiraterone was favored in terms of failure-free survival and progression-free survival. So abiraterone outperformed docetaxel. But as far as median overall survival was concerned, it was similar between docetaxel and abiraterone acetate. Only the failure-free survival was in favor of abiraterone. So many people started choosing abiraterone over docetaxel. But the question remained whether we can actually combine them. Of course, after that, there were various studies published, the Titan and the Enzamet and the Arches study. The Titan was with apalutamide, whereas the Arches and the Enzamet study were for enzalutamide. Again, there was randomization between androgen deprivation therapy put alone versus androgen deprivation therapy plus enzalutamide. So both in Enzamet study and the Arches study, the median overall survival was progression-free, radiographic progression-free survival was the primary endpoint of ENZAMET, whereas median overall survival was the primary endpoint of ARCHES. The secondary endpoint of ENZAMET was median overall survival, and both the endpoints were met. That means the median overall survival was achieved both for ARCHES and for ENZAMET. Again, the hazard ratio was around 0.68, which appeared to be quite similar to what has been achieved with 0.62 or the hazard ratios which were there for docetaxel and other studies. Now, the next phase of treating castration-sensitive prostate cancer is to combine everything. So the PEACE-1 trial, which is one of the latest studies which are published in the last ESCO meeting by Karim Fizazi, and so they brought in all the drugs. So they gave docetaxel in addition to abiraterone acetate. So PEACE-1 was not a randomization to docetaxel versus abiraterone, but or docetaxel plus abiraterone versus abiraterone alone. But they just looked at, so docetaxel became a standard of care. So they looked at the patients who received docetaxel as a standard of care versus those who did not receive docetaxel. So those who received docetaxel followed by abiraterone acetate, and they found that the median radiographic progression-free survival was improved by almost 2.2 years, and the median overall survival was also enhanced, especially in the high volumes sector or the high volume patients. So this is how things evolved. So people started arguing that actually we can give both docetaxel for 6 cycles topped up with abiraterone acetate and get the best possible radiographic progression-free survival, as also the time to castration resistance, and also time to subsequent therapy, and also perhaps median overall survival. So this became one of the notions. The ENZAMET study also had a few patients who received docetaxel followed by enzalutamide or with enzalutamide, although a smaller subset of the ENZAMET study. That did not really show any benefit of a triplet therapy. So the hazard ratio was 0.92 or something, which crossed the unity line. So if you are thinking of giving enzalutamide with docetaxel as a castration sensitive, perhaps the ENZAMET study, the subset of the ENZAMET study, was not in keeping with doing this strategy in clinical practice. The last and the best study, with the last and the most important study over here is with darolutamide, which is called as the ERASEN study, which became an NEJM publication. In this particular study, they combined docetaxel with darolutamide, and darolutamide being continued as an androgen receptor pathway inhibitor. And this particular study has shown a radiographic progression-free survival as well as an overall survival in patients who are castration sensitive. So this is one of the game changers. The toxicity of darolutamide seems to be better than enzalutamide, and perhaps so more patients are able to keep up with darolutamide as compared to enzalutamide. The drug is already introduced into the Indian market, but it's only for approved for non-metastatic CRPC setting and not in this particular setting. But the data of ERASEN studies is quite compelling. So I think in today's world, we need to look at castration-sensitive prostate cancer as either a high-volume disease or a high-risk or a low-risk disease. And if the patient is actually a candidate for receiving docetaxel or chemotherapy and has a high risk or a high volume disease, they should receive docetaxel in addition to androgen deprivation therapy, chemotherapy for about 6 cycles, and then followed by an androgen deprivation, an androgen receptor pathway inhibitor, be either darolutamide or abiraterone acetate. Cost would definitely favor abiraterone acetate over darolutamide. And and of course, then follow up. And this, perhaps the median overall survival of castration-sensitive prostate cancer, which used to be around 4 years or so, if you look at the data set of PEACE-1 and ERASEN, it seems to be crossing almost the 70 or 80 months mark, which is like in excess of 6 years. And with good quality of life being maintained for a longer duration of period, if castration-sensitive prostate cancer is treated with a triplet regime, especially those who have high volume disease or high risk disease and are otherwise good candidates to receive chemotherapy. So with this, I conclude my talk. Apologies for not being able to share the slide set. Perhaps I'd sent the slide set to a wrong email ID, but this is how I would put it.
Thank you, sir. Any which ways you have presented so nicely. Thank you for the excellent talk. And next, I would like to invite Dr. Vineet Talwar, who is Director, Department of Medical Oncology, Rajiv Gandhi Cancer Institute, Delhi. And he's going to talk on chemotherapy in prostate cancer. Over to you, sir.
Hello, can you see my screen?
Yes, sir.
Okay, so the topic which has been given to me is basically chemotherapy in prostate cancer. And this is going to be a big overlap with what has been told earlier and what has to be told later on. Suffice to say that I would be going into the hormone sensitive category, and I'll be going again into the hormone resistant, that is the CRPC category. So chemotherapy in prostate cancer, as you can see, it is the disease when it was in the CRPC state. From there, the chemotherapy drugs have progressed and gone into the hormone sensitive stage. And now there are trials in the adjuvant setting also where drugs like docetaxel have been tried. So this is the evolution of chemotherapy in castrate sensitive. So I'll be talking about CSPC once. And then after that, I would be talking about the CRPC. So initially you saw that in 1940s you had only ADT. Then after that came docetaxel. Then you had the novel hormonal therapy, and then you had the doublets. Then lately you have had the triplets, in which Manish has just now told about the PEACE 1 and the Arasens trial. So I would be touching everything bit by bit. So evidence for the upfront use of docetaxel. This was seen in the two major trials. This was the Chartered and the Stampede trial, which reported a clinical benefit of adding docetaxel to androgen deprivation therapy in patients with hormone-sensitive prostate cancer. And that was again shown to improve the overall survival, more so in the high-volume disease. And when we talk of high-volume disease, it is the presence of visceral metastasis and more than equal to 4 bone metastasis and more than equal to 1 metastasis not involving the axial skeleton or pelvis. So in the updated analysis of the Chartered trial, the median overall survival was significantly improved in patients, those who had high volume disease with an excellent hazard ratio of 0.63, but not in those patients who had low volume disease with a hazard ratio of 1.04. And this has been seen in this Chartered trial, in which you see that high volume disease definitely is benefited when you add docetaxel vis-a-vis when you see the low volume disease. The other trial which was there, that was the Stampede trial, that showed a benefit for both primary endpoints of overall survival and progression-free survival. But the fallacy here was that it included some patients with locally advanced disease also. Having said that, the majority of patients were metastatic disease and they had a HR of about 0.78, and that translated into good overall survival and progression-free survival. And this was the schema. You had a plethora of arms. You're talking about the arm C, where you find that when you combine AAT with docetaxel, you have a good hazard ratio of 0.73, and you see the curves which are separating in this graph as far as the overall survival is concerned. Another trial which is there, that is the GTUG AFU15 trial, that demonstrated a significant improvement in the secondary endpoints of biochemical progression-free survival and the RPFS, that is the radiological progression-free survival. But it could not show the overall survival, which was the primary endpoint. Probably this was attributed to the small sample size patients in which this trial was done. And you can see that the hazard ratio was 0.88, but it was not clinically significant, although there was some separation of the graphs according to this trial as far as the OS was concerned. But later on, these two trials, that is the GTUG trial and the Chartered trial, they were combined, and they found that in a pooled average in only high volume disease, there was an improvement in the proportion of patients who were alive in the both these trials, and the pooled average was a hazard ratio of 0.68, which was clinically significant. There was a meta-analysis of all the three trials, that is a Chartered, Stampede, and the GTUG trials, and that confirmed that the addition of docetaxel to ADT reduced all-cause death as compared to ADT alone in the overall population, and that translates into 94 fewer deaths per 1,000 men. But there was a caveat that it was associated with greater frequency of adverse events, grade 3 or higher, predominantly which were neutropenia and neuropathy. So with that caveat, if the patient was fit and in a position to tolerate, this was the drug which could be used to get the desired overall survival benefit. Switching gears now, what is the latest? Here you're trying to add all the three drugs, throw everything into the hormone sensitive category, because the mantra is the maximum time the patient remains in the hormone sensitive category, it is the best for the patient, because once the patient goes into the castrate resistant state, then the survival dips very, very quickly. So two trials which are there, one is the PEACE-1 trial and the ARASENS trial, which I would be discussing. Whereas in the PEACE-1 trial, you have ADT plus docetaxel and abiraterone. That definitely improved the overall survival and the radiographic progression-free survival. This was an open label study. The other one is the ADT plus docetaxel plus darolutamide, again, which improved overall survival. This was the ARASENS trial. So when we come to the PEACE-1, these are the baseline characteristics. ADT plus docetaxel, they are very well matched. You find that high disease burden is about 65% in both these sets, and 100% patients received docetaxel. So when you talk of the radiological progression-free survival, you find that the median, now we are not talking of months, we are talking of years. It is 2 versus 4.5 years, and it is statistically very much significant with a very good hazard ratio of 0.5 from the time of randomization. So this is a very robust outcome which has come when you combine all these three drugs. And when you see in high volume versus low volume, the best benefit is the one in which, when you see across the metastatic burden, the patients who have high volume, they are the ones who are doing the best. Again, in terms of years, that is 4.1 versus 1.6. Switching gears again, the ARASENS trial, in which you had darolutamide plus ADT plus docetaxel versus placebo plus ADT plus docetaxel. Here again, you find that both the arms are equally matched as far as the characteristics were concerned, whether it is the metastatic stage, ECOG, and the median serum PSA levels. And the endpoint, the addition of darolutamide to ADT plus docetaxel significantly reduced the risk of death by 32.5% versus placebo. And the OS benefit was seen across most of the groups. And this was again a very, very good trial as far as the triplet therapy in hormone-sensitive prostate cancer was concerned. So again, when we see the time to CRPC settings or the time to pain progression, in both of these situations, this triplet combination did very well And you can see the graphs are totally splaying out after just 3 months. So we were talking of the hormone-sensitive prostate cancer. Now we come to the chemotherapy in CRPC setting. Started with 5-FU, went to cyclophosphamide, then mitoxantrone, then definitely docetaxel, which became a game changer, and then cabazitaxel in 2010. And these are the agents which are approved for metastatic CRPC. And a lot has been told about the novel hormonal agents, and PARP is yet to come, I think probably the next topic. So taxanes in metastatic CRPC, docetaxel was the first generation taxane, followed by cabazitaxel. And this definitely improved the OS in docetaxel pre-treated metastatic CRPC and also improved the quality of life indices. Docetaxel in these patients can be used in chemo-naive patients, patients who are in good performance status, patients who didn't experience disease progression while receiving docetaxel in metastatic hormone-sensitive setting, and patients harboring the androgen receptor splice variant, that is ARV7, in which the novel hormonal therapy agents may be contraindicated, and these are the patients who would be the best candidates for docetaxel. Whereas cabazitaxel, the first STANA trial failed to demonstrate the superiority of cabazitaxel over docetaxel in chemo-naive CRPC patients. But there was offshoot that cabazitaxel had a low risk of neuropathy and then can be preferred over docetaxel in diabetic chemo-naive patients. The second trial, which was again a very important trial, this is the CARD trial, which was where cabazitaxel was given as second line in patients of metastatic CRPC. That conclusively showed that there was an overall survival benefit, that is 13.6 versus 11 months, in patients who were given cabazitaxel versus patients who were given second line novel hormonal therapy agents. And these are the two trials which I was talking about, the Proselica trial and the CARD trial. Proselica trial is the one in which the doses of cabazitaxel were matched, that is 25 milligram per meter square versus 20 milligram per meter square, and they found that the intervention in the control arm were almost similar, and that led to the FDA approval for the low dose cabazitaxel, that is 20 milligram per meter square versus 25 milligram per meter square. CARD trial I've shown you, that in which cabazitaxel was given and this was pitted against abiraterone, and it was found that the intervention arm and the control arm, there was a difference, and that again is an important trial in the second line. So this was the overall survival with docetaxel. The famous trial, that is the TAX 327 trial, in which docetaxel was pitted against mitoxantrone, versus the SWOG trial, in which docetaxel plus estamastine was pitted against mitoxantrone. You find that there was an improvement in the overall survival in both these trials. And again, when you talk of cabazitaxel versus mitoxantrone, you find that cabazitaxel was very much beneficial, that is 15.1 months versus 12.7, and that was the overall survival in these patients. If you talk of the second line, where patients who have already got docetaxel and have progressed, in which cabazitaxel was given against enzalutamide or abiraterone, whichever one was not given, this was continued till progression of disease. The primary endpoint was image-based PFS. The secondary endpoint was the overall survival, and it was seen that in both of these situations, whether you talk of the progression-free survival or you talk of the overall survival, there was a difference in the survival when you pitted cabazitaxel versus the AR inhibitors. This was again the Proselica study, which I had just mentioned to you now, in which the dose of cabazitaxel was decreased because most of these patients had prolonged neutropenia with 25 milligram per meter square dosages. And some of these patients used to be there in the second line who had already received docetaxel. And these were elderly patients, may not be that good. So this showed that there was not much difference when you gave 20 milligram per meter square versus 25 milligram per meter square. And so was the adverse event profile in these patients, in which you found that when you gave cabazitaxel as 20 milligrams, the febrile neutropenia was seen in just 2.1% patients versus 10%, which was in when you gave cabazitaxel as 25 milligram per meter square. So to conclude, chemotherapy in prostate cancers evolved from that of palliation, that is from the CRPC setting, and it has gone to hormone sensitive prostate cancer and is now going to the adjuvant setting, and it is improved from palliation to improvement in the overall survival. Mainstay of chemotherapy is docetaxel. Cabazitaxel has come as a second line therapy. And if you talk of the hormone sensitive prostate cancer, the institution of docetaxel earlier in the disease course have made it a default standard of care for the castrate sensitive prostate cancer along with the ADT, wherever it can be applied in those patients who have very good GC or PS, which has been seen again in the Chartered and the Stampede trial. And the further evaluation as neoadjuvant and adjuvant therapy for locally advanced high-risk disease is currently underway. Mechanism of resistance to chemotherapy is certainly an area of active investigation. And of course, decades of investigation have finally changed the treatment paradigm in prostate cancer. So if you talk of hormone-sensitive prostate cancer, you can give ADT plus docetaxel as far as the chemotherapeutic agents are concerned. If you talk of castrate-resistant prostate cancer, if the patient is chemotherapy naive, these patients can be given docetaxel in first line. In second line, as far as the CARD trial is concerned, that should be the next standard because that has given an overall survival benefit over the novel hormonal therapy agents, whether it is enzalutamide or abiraterone. So those patients, again, who are relatively fit, they can be given cabazitaxel. And it has again been seen that instead of 25 milligram per meter square, you can give 20 milligram per meter square as far as the Prosilica trial is concerned, where you don't have any dent on the survival, but the side effects like febrile neutropenia and all are much less. So I think with this, I will stop. I thank you for your patient hearing.
Thank you, sir. Thank you very much for enriching us with the chemotherapy in prostate cancer. And as we move ahead, I would like to invite Dr. Arnab Bhattacharya, who is consultant medical oncologist at Tata Memorial Center, Kolkata, and he is going to deliver his talk on PARP inhibitors in prostate cancer. Over to you, sir.
Yeah, thank you very much for giving me this opportunity, and thanks to all the previous speakers for this wonderful discussion this evening. So without further delay, we will move to the next topic. So that is the role of PARP inhibitors in prostate cancer. So is my slides visible?
Yes, sir.
Okay.
Yes, sir.
So if we see the genetic landscape of the prostate cancer, so we can see germline plus somatic alteration together. There is a huge number of patients who have shown benefit. So germline BRCA plus somatic BRCA2 consisted of around 15 to 16% together. BRCA1 germline plus somatic another 2%. And for other ATM and CHEK2 consist of another 10 to 15%. So altogether, it will come 25 to 30%. And this is the landscape of metastatic CRPC landmark trials approval. And we can see from 2020 onwards, there is approval of rucaparib and olaparib. So what are the evidences of PARP inhibition in metastatic CRPC? So the first evidence to be remembered is from Tritian 2. It was a phase 2 trial. So the role of rucaparib in metastatic CRPC with HRR gene alteration. Patient had a deleterious somatic or germline HRR gene alteration and progressed on previous 1 to 2 androgen receptor directed therapy, and one prior line of taxane-based chemotherapy also should have taken. So single arm study, rucaparib 600 mg BD, the usual dose, and the primary endpoint was with measurable disease at baseline, centrally assessed, confirmed overall response rate. So if we see the objective response rate, it is around 43%. So very good. So now the next trial for olaparib was the Triton-3, where the rucaparib was compared with physician's choice in metastatic CRPC in 2:1 randomization, who had BRCA1/2 or ATM mutation and progressed on previous AR-directed therapy for prostate cancer, and no prior PARP inhibitors or chemotherapy were allowed. So we don't have the results till now, but as per the press release that Triton-3 had met its primary endpoint of improved radiological PFS with rucaparib. So now coming to the role of olaparib, so phase 3 trial PROfound, it had compared olaparib with physician's choice in metastatic CRPC. And there were two cohorts. The cohort A consisted of BRCA1/2 or ATM alteration, and cohort B were consisted of other alterations in the BRCA gene. So here also 2:1 olaparib was compared with physician's choice, and the primary endpoint was radiological PFS in cohort A. So if we see the results, radiological PFS by BICR was 7.4 months versus 3.6 months in favor of olaparib with a very good hazard ratio 0.3. And if we see the OS, that was also in favor of olaparib, 19 versus 14 months, and with hazard ratio 0.7. So from there, from these trials, FDA approval came for olaparib and rucaparib. Olaparib got approval for metastatic CRPC with germline or somatic HRR gene mutations, progression following prior treatment with enzalutamide or apalutamide, and it was based on PROfound-3 trial. And rucaparib got approval for in metastatic CRPC with previous treatment with AR-directed therapy and taxane-based therapy, and based upon phase 2 Triton trial. Now coming to the other evidence with other PARP inhibitors like niraparib. So Galahad trial. So here the it was phase 2 trial, and response rate was seen. So single arm study. So niraparib has shown objective response rate around 34% and PSA response rate 43% patients. And the evidence for talazoparib with a response rate in metastatic CRPC with the DNA damage repair mutation. So here also you can see the objective response rate is around 45%. So now how do the tumor behaves with non-BRCA mutations with PARP inhibition? So if we see PROfound, there were two cohorts, cohort A and cohort B. If we analyze the both cohorts together, cohort A and B together, so we can see there was a benefit of a median OS in the favor of olaparib arm. And if we see the subset analysis, there were also benefit for most of the subsets in favor of the cohort A and cohort B together. And so PARP inhibitors monotherapy, if we summarize, so PARP inhibitors monotherapy is now standard of care for BRCA1 or 2 mutated metastatic CRPC after abiraterone or enzalutamide. So olaparib got approval in this setting, or after AR targeted therapy and taxane, rucaparib got approval. And if the patients have other mutations apart from BRCA, so there olaparib got approval. So what is the role of PARP inhibitors in combination with other therapies? So there are numerous trials going on, and so olaparib in combination with abiraterone or immunotherapy like pembrolizumab, talazoparib with enzalutamide immunotherapy and other agents, rucaparib, niraparib also have numerous other agents with combination. So what is the rationale of co-targeting AR signaling and PARP? So preclinical evidences are there for potential synthetic lethality. PARP1 interacts with androgen signaling, and castrate-resistant tumor cells exhibit increased PARP1 activity. And preclinically, PARP1 inhibition synergies with AR-targeted therapy. So here in the mouse xenograft model, we can see that if we give castration for PARP inhibitors together, so there was the most response we can see. So, so the PROPEL trial was the first line abiraterone plus minus olaparib in metastatic CRPC. So no prior treatment were allowed except docetaxel in the metastatic hormone sensitive prostate cancer setting, and with ECOG performance status 0 to 1. In this trial, no screening for HRR mutation was done. That was optional only. So irrespective of the HRR mutations, so patients got olaparib, sorry, abiraterone in one arm versus abiraterone plus olaparib in another arm. And the primary endpoint was radiological PFS. If we see the result, so radiological PFS by BICR, the median RPFS is 27.6 months versus 16 months with a good hazard ratio in favor of the olaparib plus abiraterone arm. And if we see the side effect profile, so grade 3/4 adverse event were 47% in combination arm versus 38%. And the most common adverse event were 15% anemia versus 3.3% in the abiraterone arm. So mostly these were due to the olaparib. Now coming to the next trial of combination of abiraterone plus minus niraparib, that was the magnitude trial. So here also no prior systemic treatment were allowed except prior abiraterone were permitted for metastatic CRPC if it was there, it was part of treatment of less than 4 months if it was started. So here there were two cohorts, HRR mutation positive cases and HRR mutation negative cases. So niraparib was compared, niraparib plus abiraterone was compared with abiraterone alone. And if we see the results, HRR mutation positive cohort, the hazard ratio was 0.7, and they have again checked for BRCA1/2 mutated subset also. So there was a much improvement with a much improved in the difference of HRR 0.53. However, HRR mutation negative cases, there was no benefit. The chart is not available in this slide. And if we see the treatment related adverse events, so grade 3/4 adverse event was 67% versus 46%. And again, here also anemia were the common side effects, grade 3/4 side effects, 13% in niraparib based combination therapy, and thrombocytopenia were also common, around 3%. So these are other trials of combination like enzalutamide plus minus rucaparib, enzalutamide plus minus talazoparib. We have to wait for the results. This particular trial, pembrolizumab plus olaparib were compared with enzalutamide or abiraterone. So if we see the results, so however there is no much improvement with the standard of care of combination of olaparib plus pembrolizumab. And this was this is another trial, radium plus olaparib versus radium. So here phase 1 trial, and so I'm not going into details. So there was another concept, is earlier disease a better target for AR plus PARP inhibitors therapy? Because if we see the natural history from clinically localized disease, it might progress through the metastatic hormone sensitive or non-metastatic hormone resistant, and then ultimately metastatic hormone resistant. So different trials are going on in different settings with PARP inhibitors plus hormone therapy, and we have to wait for the results. And so if we come to a decision from the combination of PARP inhibitors with these hormonal agents, so the magnitude trial in patients of having metastatic CRPC patients, so niraparib plus abiraterone versus abiraterone, there was a benefit with HRR alteration. However, there was no benefit of HRR mutated HRR mutation negative cohort. And from the PROPEL study, we can conclude that olaparib abiraterone plus minus olaparib, there were improvement, but however patients were not stratified by HRR status. So the discrepancy of outcome between this magnitude and PROPEL raises the concern regarding the routine use of PARP inhibitor based combination therapy in an unselected patient population. So we need more data before starting at a standard of care of this combination agent. So with these things, I'm stopping here, and if there are any questions, I will be happy to take. So thank you, and over to the organizer.
Thank you, sir. Thank you for the wonderful talk. Any questions from the panelists? If no, then we can move forward. And I would like to invite Dr. Amit Rothan, who is consultant medical oncologist, Manipal Hospital, Bangalore. And he's going to talk on sequencing of systemic therapy in prostate cancer. Over to you, sir.
Thank you very much. Right. Okay. Good evening, everyone. Thank the organizers for giving me this opportunity. There have been a lot of wonderful talks which have shown the data about how we manage prostate cancer, but now the last talk probably will be just sequencing of all these systemic therapies and what we do in clinical practice. So we've seen the prostate cancer landscape. Eventually, every prostate cancer who gets into a metastatic space, even if they are hormone sensitive, but will eventually become metastatic castration-resistant prostate cancer. And we have to learn how to sequence our drugs so that we can manage these patients better, especially in the castration-resistant prostate cancer space, and increase the life of patients. So we've seen all these successful phase 3 trial data sets. These have been the ones which have formed our practice guidelines for in the metastatic castration-resistant prostate cancer space. So what we used to do earlier was, whenever we had these patients, docetaxel, because of its superiority in the TAX 327 trial, had become our standard of care, and it had shown a clear improvement in overall survival. So we used to give docetaxel to most of our patients. And then when the hormonal therapies came up and we saw abiraterone and enzalutamide, both of these first initially came in the docetaxel resistant space, and then they came on in the pre-docetaxel space. So our management became more and more in the sense of using hormonal therapy first, and then most of these patients would get exposed to abiraterone or enzalutamide, and docetaxel used to be given after the usage of these drugs. And this is how we are practicing in most of our patients in the metastatic castration-resistant prostate cancer space. So it could be we start with ABI, or we can start with ENZA, and then when patients progress, what we used to do earlier, we used to go to DOSI, but once we started getting ENZA usage, we started moving from one hormonal to the other hormonal, thinking that it would work for our patients. But then we have learned now that that may not be the best option in this group of patients. When they move from ABI, ENZA, and then they progress, and then we start exposing them to docetaxel. But yes, if we use docetaxel in the metastatic castration-resistant space, then we used to move to the hormonal therapy space. And of course, there are the other drugs. We have seen the cabazitaxel data. There are other opportunities which we don't have available in India. We don't have radium-223 for our patients. And we've recently seen the data sets presented for the newer agents. We've seen olaparib just now being presented, and we have also seen lutetium data sets being presented in the VISION data. So how are we integrating now in clinical practice? It's a changing management, and we are doing a lot of changes because of the new data sets which keep coming in. So one data definitely which is practice changing for us is the CARD study, which Dr. Vineet just showed us. In CARD, so when we move from one hormonal to second hormonal in CARD, we have seen clearly that when you move from one hormonal to the second hormonal, that may not be the right way to do it. It's better to change to cabazitaxel in the post-docetaxel space. So if your patients get DOSI, progress, and if they have exposed to abiraterone, if they progress, it's better to give cabazitaxel. So this is clearly a good sequencing strategy we have learned. And nowadays, it's in rare patients, those slow progressing patients, that we really change from ABI to ENZA or ENZA to ABI. And most of these patients, we would either just switch to cabazitaxel after the docetaxel space. There was also one more data set in which recently we saw, is it better to do ABI to ENZA or ENZA to ABI if we do it? And there's more and more talk that it's better that you probably should do ABI first and then ENZA, because when you do ENZA first, ABI after ENZA is really not showing much response. Though there's always been a controversy in this, but slowly the data sets are emerging this way. But of course, I don't think we should do any of those if our patients are rapidly progressing. It's best to go to cabazitaxel in that group of patients. We also saw the olaparib data, the PARP inhibitor data just presented, and PROfound also has kind of shown us one more approach for the HRR positive patients. We have seen that we improve PFS and we improve overall survival, at least in the cohort A group of patients, those with the BRCA positive patients, and of course the ATM were also there, a part of cohort A. So this is another opportunity for our patients. Now, where would we place olaparib for our patients? In the metastatic castration-resistant prostate cancer, patients who have received one line of hormonal therapy and then they progress, or they may have received one line of taxane and then progress. So they should have received one novel hormonal therapy, maybe one plus minus one taxane, and you find HRR positive, then that is the space where we would go to olaparib. This again is changing very rapidly, but that's the current space where we are putting olaparib for our patients in the castration-resistant prostate cancer space. Lutetium data sets came out. I think this is something that is also useful for our patients, especially when they have progressed on the taxane and on one line of androgen receptor pathway inhibitors. And this trial again showed a clear improvement in overall survival. So this is something that you could use for your patients after exposure. Again, whether you use it a little higher, I don't think so. I think we'd still place it a little lower down the line after our hormonal and after our taxane exposure, maybe even after cabazitaxel exposure. Probably that's where this would come in for our patients. So this is how the landscape has changed dramatically. So now we have all these therapies in the metastatic castration-resistant prostate cancer space, and you can put in a list of agents, but a lot has changed because the earlier lines of therapy has changed. And that is what is making a significant impact on how we choose therapies. I think this non-metastatic CRPC indication will change again our management of our resistant population. If we are using the AR inhibitors, and especially these potent novel AR inhibitors in the first line non-metastatic space, and when these patients progress, obviously AR targeted therapy may not be the way forward, and these patients may end up directly with chemotherapy, or maybe PARP inhibitors may have to be used. So this is something we learn when these patients when we start using these extensively and these patients start progressing. Secondly, we just now saw the data of PARP inhibitors, and we saw how the PROPEL data, again looking at the metastatic CRPC space first line. Now, here, olaparib abiraterone versus abiraterone, you saw an improvement both in the radiological PFS, and what was clearly seen, which is very difficult to explain, was the benefit was seen in both the HRR mutation positive patients and the non-HRR the patients, which is very surprising to see. And as mentioned just in the previous talk, again, we've seen the magnitude data where the HRR biomarker positive patients responded equally the same, but the biomarker negative population did not respond. So clearly telling us biomarkers are important. I don't think we can extrapolate data for all our patients, but yes, at least in the HRR biomarker positive, clearly we are seeing adding the PARP to the novel hormonal in the first line setting is better than using the hormonal therapy alone. So this again is going to change our way we look at our metastatic CRPC patient space. And we also heard about the Arasens triplets. So we always say for the hormone sensitive space, doublet is the standard of care now. You hardly treat a patient with single agent LHRH. You always say you treat patients with doublets. But with the coming of PEACE-1 and the Arasens data, where you saw clear improvement in the overall survival when you use the triplet versus doublet. So it may happen that very soon you will move the triplet into the first line space in the hormone sensitive space. So you end up giving ADT, you end up giving docetaxel, and you end up giving a novel hormonal therapy. The darolutamide is being given. So your patients are already exposed to all these lines of therapies. Now, when they progress, what are you going to offer them? And that's going to be a very, very interesting conversation again with our patients. Should we go in directly to cabazitaxel now because they have progressed on this? Or will these patients benefit for using maybe a PARP inhibitor combination there? We don't know this. And that's why, though the triplet responses are very, very good and everyone's very encouraged by it, but it does lead to questions that what would we do when patients progress on the triplets? And this is again something that time will answer. And as our usages changes, we will answer. So I would like to kind of say these are what we do in clinical practice and what are our considerations for sequencing. There is no one right answer for sequencing, saying this is the way you should sequence your patients. You should look at your patients when they come to your clinic. We will always assess their performance status. We will assess their comorbidities. This is especially important when we are talking about chemotherapy. We may have patients, but they may not be eligible for chemo due to their fitness. So that's very important. And those patients would go in more in the direction of hormonal therapy or maybe in the direction of PARP inhibitors sometimes. We should see their symptoms, their burden of disease, and that will probably help us in, again, choosing whether we want to be aggressive, whether we want to use combinations, or whether we could still stick to single agent therapies. I think what is going to be the most important factor, what is the previous treatment taken in the metastatic hormone sensitive space, and also now what is taken in the non-metastatic CRPC space. And these therapies which you take upfront will guide what you will do in sequence and subsequent lines. And this will be a very important learning curve for all of us. Genomic information, whether the patients are BRCA positive or negative, whether they are HRR positive or negative. Again, these are very important decision-making tools which will help us choose PARP inhibitors either in single agents or combinations for our patients. Of course, we eventually talk a lot about various therapies, but cost plays the most important part. We know how expensive some of these therapies can be. The cost of treatment is also a very important factor. Availability is another important thing. We don't have lutetium, then there's no way you can offer that to your patients. We still don't have radium in India, so that's something we don't offer our patients. And lastly, whatever you say, a lot is based on what patient wants. So you may want to push chemo onto your patients, but your patient preference was, no, I want hormonal. So that will be how you will be choosing your patients. So I would like to conclude. I think sequencing for prostate cancer patients is an art, and all of us are going to adapt more and more and become better and better as we start using all different therapies in different lines. And as we move aggressive therapies upfront, I think that's how we are going to then learn how to use our subsequent therapies. So with this, thank you very much.
Thank you, sir. Thank you so much for the excellent talk. And as we come to the closure of the meeting, I would like to announce, yesterday we had abstract presentation, and I would like to announce the abstract winners before the words of wisdom from Dr. Shyam, sir. So Ayush, can we have the slides? Just announce the winners of the abstract presentation. So here are the winners. So first prize goes to Dr. Karthikeyan from Ooty. Second prize goes to Dr. Ojas Vijayanand Poddar from Chennai. And third prize goes to Dr. Paulami Ghosh from Kolkata. Heartiest congratulations to all the winners. And now I would like to invite Dr. Shyam Agarwal, who is Director, Department of Medical Oncology, Sir Gangaram Hospital, Delhi, for the words of wisdom. Over to you, sir.
So good evening, everyone, and thanks very much for this opportunity. I must thank each and every person, who has contributed to the success of this meeting. Speakers were really wonderful, and the last 3 hours was an academic feast in the area of prostate cancer, starting from screening onwards onto the treatment of early prostate cancer, then going through the advances which we are seeing in metastatic disease. So I think it was really, I learned a lot from all the talks from all the speakers. Just to say a few words on how the area is evolving. I think the first talk was on screening, where there is no consensus at this point in time. However, any person who has symptoms or who is asking for screening, he must not be refused. So I think although the numbers required for screening and for saving lives have come down, so I think we are making a headway for some kind of a screening for normal men. But then we still are not offering it to each and every person at a universal level. The second, talk was, which I really liked, was the issue of multi-parametric MRI in the diagnosis of early stage prostate cancer. I think we must do that because, that really tells you the location of the disease, the nodal involvement, and so on. So I think we must ask for a multi-parametric MRI for patients who deserve it. Now, coming to the management of early prostate cancer, there was, I think the radiation oncologist clearly said that if a patient is under the age of 70 years and otherwise fit and has no high risk features, so he should be offered the surgical therapy because there are a lot of advances there, including robotics. But then if you have high risk features, well, sure, the radiation and the ADT should be included in such treatment. But I think a lot of advances which we all know are there in the field of advanced or metastatic prostate cancer. I think we all are aware that this terminology of non-metastatic CRPC has emerged, where you have this new drug available called darolutamide. So I think we really need to screen patients for the utility of darolutamide, especially if the doubling time for the PSA is low and patient is fulfilling the criteria. I think the biggest evolution is happening in the management of HSPC, where from bicalutamide, we have really had a pretty, a solid run, where we are not only talking about one or two drugs, but as we heard from Manish and again from Vineet, that the 3-drug combination is possibly, good, because the PFS is really, exemplary, and the hazard ratio is very robust. So for fit patients with visceral disease and a lot of disease, I think a 3-drug combination is on. I think, and we have started using that in our day-to-day practice. Of course, as Amit pointed out, olaparib or PARP inhibitors are knocking on the door for CRPC. But the problem there is that this is in combination with olaparib, and if you use in combination with abiraterone. So but I think most of us are using abiraterone in first line in HSPC. So there is a washout period required for 12 months before we can combine it with olaparib. So I think that is going to be a big hitch. But that brings us to the point of doing the HRR testing or BRCA1/2 testing. So I think we need to join hands with the radiation oncologists and surgeons to impress upon them, because most patients would go to them early to do the BRCA1/2 and HRR testing on the tissue, even once the patient even has HSPC. So rather than waiting for too long. So I think that is one thing which we really need to impress upon our colleagues to perform the BRCA1/2 testing early in the course of the disease, because that will give us a handle as to what we should be doing next. I think the lutetium PSMA treatment data is very promising. It is available in big towns. So I think so it is competing actually with cabazitaxel after a patient has failed chemotherapy and maybe first-line hormonal therapy. Finally, a word about genomics and immune drugs. We haven't really made a big progress there because MSI is also should to be tested, and the incidence of MSI high is quite low. I think the other issue which we have not been doing is the NGS or the ARV testing, which could help us figure out who should be benefiting from chemo versus these hormonal therapy. But I think we need to join hands with the labs and again discuss doing NGS or especially looking at the ARV mutation so as to figure out what is the best line of action. So I think we really have come a long way in the management of prostate cancer from the days of bicalutamide to a plethora of drugs and better PFS and actually overall survival and quality of life. But I think it has to be a multidisciplinary approach where the surgeon, the radiation oncologist, the radiologists, and even the lab personnel have to join hands along with the pharma and medical oncology colleagues to deliver the best. So I think with this, I congratulate all the speakers. I congratulate all the organizers, especially Professor Advani and Dr. Kumar Prabhash, who's taken all the pains to organize this wonderful meeting on a virtual platform. So over to Kumar for your final words. I am sure you're there. Thank you very much for the opportunity.
Thank you, sir. Thank you for kind words, sir.
Thank you, sir. Thank you, Dr. Kumar, sir, Dr. Sham Agarwal, sir, for your words of wisdom. And I think we had a brilliant 2-day academic feast. And so we come to the end and hopefully we'll be meeting next year.
Thank you so much, Ekta. So on behalf of Glenmark Oncology, I would like to thank all the doctors for their patient hearing and their esteemed presence. Once again, thanking all the patrons, organizing chairman, advisory committee and scientific committee, and of course, speakers for their esteemed presence. Have a great evening. Thank you so much on behalf of, once again, Glenmark Oncology. Bye-bye.